Hello, hello, check, check, hello, hello, check. Yes, sir. Hello, hello, check, check, test, hello, hello, check, hello. Hey, das. Hello,
ওং সহনা ভবতু সহনো ভুনক্তু সহ বীর্যং করভাবহৈ তেজস্বী নবধিতমস্তু মা বিদ্বিষাবহৈ ওং শান্তি 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 হরি ওং তৎসৎ. We have come on the second day of this academic extravaganza called Crescendo 2024. We have listened to many stalwarts. We are going to listen to many stalwarts today. And it's an academic shower for all of us. So without much further delay, we'll initiate our today's academic symposium or academic program, for which for the beginning, for the inauguration, and for the initiation of this academic extravaganza, I would like to call upon stage Professor Narendra Kotwal sir, Director and an eminent endocrinologist, the Left General Dr. Narendra Kotwal sir, who has been AVSM, SM, and retired VSM, Director Endocrinology of Paras Hospital. Sir has got many laurels over his head, and sir will guide us over the thyroid hormone replacement. We are all eager to learn. Sir, please bless us with your knowledge. Thank you, sir.
Thank you very much. At the outset, good morning, everyone. At the outset, I would like to thank the organizer to give me this opportunity. And in fact, Crescendo is crescending new heights every year. And thank you very much again for inviting me. Now, you see, hypothyroidism is one of the commonest endocrinopathy which we come across, and most of us have treated all these patients. Despite the fact that we know that levothyroxine is the treatment of hypothyroidism, there are caveats in the treatment. There are the patients who are undertreated, there are the patients who are overtreated. So why it is so, we'll discuss that part. Now, as far as the treatment, goals of treatment are concerned for hypothyroidism, it is with the thyroid hormone replacement to the resolution of the symptoms and to achieve euthyroidism and to have the biochemically normal TSH. And how do we treat? By giving levothyroxine. Where all levothyroxine is used? It is used in hypothyroidism, as a suppressive therapy in thyroid nodules in thyroid carcinomas. Earlier, it used to be used in the diffuse goiter, but no longer we use it. Misuse of levothyroxine is in the weight loss, so-called metabolic insufficiency. Now, point to remember is that levothyroxine sodium has a very narrow therapeutic range. Regardless of the indication of use, careful dose titration is necessary to avoid over or under treatment. Even small changes in levothyroxine can shift a patient from euthyroid to hyperthyroid or hypothyroid. So it is pertinent to use same brand, whatever you are using. Levothyroxine has a long half-life, 7 days. 80% of it is absorbed in the jejunum and ileum. Dose is invariably in hypothyroidism is 1.6 to 1.8 microgram per kg body weight. And point to remember that it takes about 6 weeks for equilibration. So whenever we initiate the treatment, repeat TSH should be done after about 6 weeks. Whenever we are using levothyroxine, we will find that TSH is normal, but you may find in hypothyroid patient FT4 may be slightly on a higher side if you want to achieve normal T3. This point I will discuss further later on. And in some patients, owing to different half-lives, intermittent hormone injection may result in normal or even elevated thyroid hormone levels, but fail to normalize TSH. Now, it's an important points are that improper storage leads to reduced potency of levothyroxine. Normally, the bioequivalence remains unchanged over a shelf life of more than 36 months. Exposure to sunlight, high temperature, humidity, and oxygen significantly accelerates levothyroxine degradation. Exposure to direct sunlight for 80 minutes results in 60% decomposition. Blister packing may eliminate refractory hypothyroidism due to improper storage. Now, how do we titrate levothyroxine? There's a study conducted on 50 patients without cardiac symptoms who were given high dose levothyroxine, that is 1.6 microgram, at gradually incremental doses. So, and levothyroxine was also given at bedtime, and adjustment was done every 4 weeks. I don't have pointer here. Can I have a pointer? Now, point to remember that even after 20 weeks, after 15 to 20 weeks, TSH in levothyroxine, whether you give high dose or gradually incremental doses was the same. So the patient without the cardiac symptoms, you can give upfront high dose. Also, you can start the upfront high dose. Whereas the patient with ischemic heart disease, treatment should be initiated with a low dose, 12.5 to 25 microgram. Dictum is that start low and this one. Okay. Dictum is that start low and go slow. May be prudent to initiate therapy with low doses in elderly patients. Now, dose requirement depends upon the underlying thyroid function, if there's a residual thyroid function. This is a study to show that requirement is based on the body weight. Patient of autoimmune hypothyroidism, they have some little bit of residual function. Dose was around 1.62 microgram. Post radioablation, because after radioablation, it takes some time to achieve total hypothyroidism or euthyroidism. Dose was 1.54, whereas patient where total surgery is done, dose requirement was on higher side. No, always it is prudent to use levothyroxine early morning empty stomach. This was a study to show that if patients were given levothyroxine early morning empty stomach or with the coffee or with the water. Now you see that peak T4 after water was 52 and with the coffee was 36. So whenever you are giving levothyroxine, it should be given with the water, not with any caffeinated drinks. Institution of replacement, as I told you, depends upon the degree of hypothyroidism, age and general health of patient. Rapid institution may be required in certain cases. Less dose is required in central hypothyroidism and post-ablation. High dose in infants and children. Now, dose requirement is 1.6 to 1.8 microgram per kg in adults. In elderly, if you are giving in suppressive doses, it's 2 to 2.5 microgram. In elderly, as I told you earlier, start low, go slow. And patients with coronary artery disease should be around 12.5 microgram and gradually increase the dose. In congenital hypothyroidism, to start with 10 to 50 microgram. As soon as the pregnancy occurs, dose requirement increases. We increase the dose by 30 to 50%. Now, this is a very beautiful cartoon to show that variability in the TSH dose. If you see if it's given the early morning with the breakfast, there's the least variability. If with the breakfast, there's a variability, and if it's given at night, there's a variability in the TSH. So that is the reason that levothyroxine should be given in the morning. Now, once you start the treatment, what is the response? A response that initially patient may have diuresis. Why? Because gag which imbibes water, the fluid starts coming out. Then serum sodium, if it is low, it starts coming up. Pulse and pulse pressure become normal. Appetite starts improving. If there's a constipation, that improves. Psychomotor activity improves. DTR improves. Hoarseness of voice and skin hair changes take longer time to improve. Increased requirement is, as I told you, is occurs in pregnancy if there are associated GIT disorders because there's a decreased absorption. Certain drugs like which interfere with levothyroxine absorption, like risperidone, sucralfate, aluminum hydroxy, invariably patients of hypothyroidism are taking calcium carbonate or iron. So there should be time gap between giving levothyroxine and all these because they will interfere with the absorption. And drugs which increase the metabolism of levothyroxine, like rifampicin, carbamazepine, estrogen, phenytoin, sertraline, statins, and drugs which block T4 to T3 conversion, like amiodarone, and drugs which block deiodinase synthesis. Now, there will be decreased requirement in persons who are elderly, like age more than 72 years, because lean body mass is less, and somebody on androgen therapy. What should be the target once you have started levothyroxine? Preconception, lower quartile of reference age, less than 1.2. Pregnancy first trimester should be pregnancy trimester TSH specific, but generally less than 2 to 2.5. Children with congenital hypothyroidism less than 5. Young patients 1 to 2.5. Middle age 1.5 to 3. Elderly patients less than 65 around 4.5. And elderly more than 60 to 70 around 6 to 7. Generally, what I follow is that after 60 years, if somebody is 70, TSH around 7. If it is 80, around TSH 8. The point to remember is that analysis of relationship between TSH and the FT4 in a population illustrates that rather than being a simple linear relationship, the relationship may in fact be more complex and curvilinear. The slope of relationship appears to be affected by sex, age, genetics, use of levothyroxine, with each individual having TSH and FT4 set points that differ from the population as a whole. Now, TSH on LT4 treatment. Now, this was a study to show more than 1 lakh patients who were using levothyroxine, and study was for 23 years. And in this study, what they found that 11.6 of the patient had TSH values which were below zero point 0.4, and 32.4 had a TSH values above 4. Roughly more than 43% of the patients did not have TSH within the normal range. What about using other biomarkers like sex hormone, binding globulin, osteocalcin, cholesterol, creatine kinase? I just mentioned here for the mentioning sake, but as such in day-to-day practice, these are not used. No, levothyroxine in specific conditions, like in pregnant patient, I told you that upfront we have to increase the dose. In children, they require a high dose. Non-adherent patient, we have to go into the detailed history, why patient is not taking, and accordingly institute the therapy. In central hypothyroidism, I told you lesser dose is required. Older patients and patients with medical conditions, so start low, go slow. In hospitalized patient, in one of the studies found that in hospitalized patient, levothyroxine stopped, and patients ICU stay was increased roughly about more than 7 days if levothyroxine is not given. In coexistent adrenal insufficiency, it is prudent to institute steroid therapy and then start the replacement therapy with levothyroxine. So how do we monitor? Monitoring as of now is by the TSH. Now here's a one patient who is hypothyroid, and T4 is 3.6 and TSH 20.6. We can see this is a patient of hypothyroidism who was not taking treatment at all, and he has come to the clinic. Another patient, T4 is normal and TSH is 10.5. Then patient is taking drugs sometimes, but is a non-compliant. Another patient, T4 is on a more than normal and TSH is more than TSH is also abnormal. He's the patient who is non-adherent, but on the day prior to surgery, 2-3 days, he has started taking treatment. So these are the common scenarios which we see in day-to-day practice. So TSH normals and symptoms persist. One is appropriate TSH is not achieved, so we look for why it is not achieved. Autoimmunity rather than thyroid status negatively affects the quality of life. Look for the coexistent autoimmune diseases with symptoms. Symptoms caused by accompanied conditions or comorbidities, look for those. Incorrect attribution and unrealistic expectations. Awareness of the chronic condition, and so-called tissue hypothyroidism. Now, TSH may be achieved, like TSH is basically at the level of the pituitary. But tissue hypothyroidism, due to various reasons, which I will discuss, that at the level of tissue, T3 is less, which is the actual hormone which is acting at the nuclear level, but TSH is normal. Because of the tissue hypothyroidism, some of the patients, around 10 to 15% of the patients, may be having these conditions. So for the increased TSH, please look for the compliance, which is the commonest cause that patients are not taking. GIT disorders, look underlying celiac disease, bioavailability of the drug. Now, what about using T4 T3 combination? Now, prior to levothyroxine, desiccated thyroid hormones were being used, which had a T4 T3, which is a higher concentration of T3. But as of now, we are using T4. As I told you, some of the patients may be having tissue hypothyroidism because of the so-called deficiency of T3. What about using T3 T4 combination? Now, recently, this Thyroid Association, Joint British Thyroid Association and Society of Endocrinology came with a consensus. As per them, that the patients with a confirmed hypothyroidism and persistent symptoms who had not adequate treatment with levothyroxine and whom other comorbidities have been excluded, a trial of levothyroxine combined therapy may be warranted. The decision to start treatment with levothyroxine should be shared decision between patient and clinician. For individuals on levothyroxine with the normal TSH, one may start with the decrease the dose of levothyroxine by 12 to 25 and dose of levothyroxine by 2.5 to once a day or twice daily. For monitoring peak levels, there's no consensus that how should we monitor. Should it be monitored by the T3 levels, T4 T3 ratio or FT3? But as of now, serum T3 should be assessed 2 to 4 hours after the levothyroxine consumption. Normalization of serum TSH and the optimization of symptoms remain the treatment goals. If no symptomatic improvement is noted, levothyroxine monotherapy should be resumed and levothyroxine should be stopped. So this is the flow chart that a patient with persistent symptoms while taking levothyroxine, confirm the diagnosis of overt hypothyroidism. If TSH is more than, start the treatment, optimize LT4 to maintain serum TSH in the reference range, investigate for the possible non-thyroid illness. Now, having discussed all those, patients still have symptoms, TSH is normal, discuss the options with the patients. And how do we institute the levothyroxine treatment? Roughly 1:3 is the ratio decreasing the dose of levothyroxine. Just to give you an example, if somebody is on 100 microgram of LT4, so if we start 5 microgram of LT3, 5 into 3 is 15, so 85 microgram will be levothyroxine and 5 microgram will be the LT3. Now LT3 can be given in 2.5 BD or once a day. Now, since levothyroxine has got a very short half-life, there will be the peaks and troughs, so patients may go into the fluctuating symptoms. So now, novel drug delivery formulations are being looked at, like like sulfated T3, so that sulfated T3 it will have a longer half-life, or the polyzinc associated T3, so that it has a longer half-life and gradually T3 is released, but these are still in the pipeline. So if this just to give an example, in day-to-day scenario, we do come across such patients, patient of weight gain, 48 years old lady, weight gain of 6 kg over 6 years, T4 was normal, TSH was slightly on higher side, and she was put on levothyroxine 50 microgram per day. So in obesity, as such, TSH is slightly on higher side because leptin is increased from the adipose tissue, and leptin increases TRH, which increases TSH. So TSH may be slightly on the higher side. So levothyroxine use here in this patient is the misuse of the levothyroxine. Now she further gains 2 kg over in next 1 year, and TSH is normal. So in obese patients, if TSH is slightly on higher side, please do not treat with the levothyroxine. Subclinical hypothyroidism, I believe, has been discussed yesterday, so I'll skip these 2 slides. Post-tabulation, a patient comes, T3 is 92, T4 is slightly on the low side of normal, and TSH is 2.5, normal TSH. But this is a patient in post-ablation, we would expected TSH to be on lower side. TSH has started coming in the normal range, and T4 is on normal side, is on the lower side of the normal. So this is the patient who is going into hypothyroidism. If somebody's TFT is done in a patient and we do not know why levothyroxine was started, like 32 years male, no family history, no goiter, euthyroid, previous records are not available. They do come across in our OPD. So what do we do? So we can decrease the dose by 50% in the dose, repeat TSH and T4 after 4 weeks. If TSH starts increasing, then we restart the dose. If TSH is normal, then we stop the levothyroxine, again repeat the test after 4 to 6 weeks. Depending on that, you take the call. In emergent surgery, patient are hypothyroidism, emergent surgery is to be done. Now, should we postpone surgery or go ahead with the surgery? In emergent surgery, please observe closely for the CO2 retention, bleeding, infection, hyponatremia, and one can go ahead with the surgery. In myxedema, it is a game of all H. Please take care of all H, like hypoxia, hypercarbia, hyponatremia, hypothermia, hypocardia, and treat those and thyroid hormone replacement along with the steroids. Thyroid, diet, and alternative approaches. In the net, you see so many supplements are available if you go to the net. But as such, there is no evidence to show that all these drugs, all these nutraceuticals are helpful. All these patients are hypothyroidism as of now should be on the levothyroxine replacement. To summarize, hypothyroidism is a common endocrinopathy requiring lifelong therapy with thyroid hormone replacement if it is autoimmune thyroid disease. The results of levothyroxine initiation and adjustments are believed to provide patient satisfaction with therapy in majority of the cases. Levothyroxine therapy must be continually monitored as those requirements may change across lifespan and with the changes in a patient's physiological and medical situation. A subset of the patients who do not feel well while taking levothyroxine despite the best attempts to optimize therapy. For such patients, maybe a trial of levothyroxine by decreasing the dose of levothyroxine for a short duration can be considered. And if they don't improve, then levothyroxine can be restarted. Thank you very much for your patient hearing.
Thank you. Sir, that's an indeed a splendid presentation. And needs to mention that it is the great experience to have it from you. So, any questions from the floor?
Yeah, that was indeed very lucid and comprehensive. But the food for thought, the leothyroid, it's a new entity, and at the same time, tissue hypothyroidism is a very good concept to believe. But do you actually believe in it? Because there are studies which have attributed the symptoms to the gross domestic product or GDP of the country in Europe, rather than tissue hypothyroidism. So, really, do you think, on theoretical grounds, I think we have reasons to combine LT3 and LT4 in a subset of patient, at least of primary hypothyroidism. But practically, do you think is levothyroxine needed at all?
Great question. Now, theoretically, as you said, there is a sound evidence to give levothyroxine. Practically, I have not used so far, but I have come across the patients who have taken it, and some of them felt really very nice. But as of now, practically, I don't have any experience. But on growth, scientifically, if you look at, and if you look at the studies also, there are some set of the patients who may have dehydrogenase, that problem in the dehydrogenase, or as such, if you look at the dehydrogenase at the pituitary level and at the tissue level, their ubiquitation is slightly different. TSH becomes normal, but at the tissue level, the T3 may be low. That is theoretical aspects. But I would like to listen from the seniors if they have used levothyroxine.
No, actually, we hardly ever.
I have also not used, but
No, I have also used in a couple of patients. The two patients that I've used are incidentally patients of central hypothyroidism, where I found with T4 given, the T4 going high, the T3 is low. There I have changed and the patients have felt well. But again, I said there are theoretical grounds, but I do not.
But I know in Pune once this Dr. Uni was delivering lecture. He has used in certain patients. As per him, patients really felt nice.
Yeah.
You know, there are some patients where T3 persistently remains low for reasons we don't understand.
Yes.
That's one group where we've used a few patients, handful.
Right.
And the other is some of our patients already take it because they travel somewhere or someone
They
prescribes
read
and they
somewhere.
come back.
Yes.
And then if they're doing okay, let it be. I
Yeah.
don't necessarily push them back to
Right.
just plain thyroxine.
That's what even that consensus says that look for the 6 months if patients don't have to stop it.
Changing the topic a little from T3, a lot has been discussed. What about the concept of deciding the dose of levothyroxine on the basis of ideal body weight? I'm asking this because a patient comes to you with a body weight of 100 kg. And the ideal body weight is 60 kg. So you'll calculate the dose based on 60 kg and vice versa.
So whatever dose calculation is based upon the lean body weight. So ideal body weight in a elderly, in obese person also, as per that, they say ki slightly use the higher dose. High dose. So dose calculation is on the lean body weight.
Thank you.
So a young patient who is on suppose 50 microgram of thyroxine, after 4 to 6 weeks, a TSH value is less than 1, but within the normal reference range. Patient is clinically absolutely fine. Shall I reduce the dose?
At 50 years, in fact, I would like to keep TSH somewhere between 2 to 4, like that. If it is TSH is 1 and patient is asymptomatic, now one can repeat again after 4 to 6 weeks. See, if it is still 1, then one may decrease little bit.
Sir, based on body weight, it is 1.6 milligram per kg of body weight. Should we start straight away calculating 1.6 per body weight, the full dose, or we should build up the dose starting from a lower dose?
So as I discussed earlier, if it is a young individual without any cardiac illness, you can start with a high dose. But elderly patient with the cardiac symptoms start with a low dose and gradually increase. But if it is a young individual, no comorbidities, one can start with the full dose.
Thank you.
Yes, sir.
I don't know what's the experience of others, but many patients, most patients don't require 1.6 microgram per kilogram. They require much less. And by and large, hypothyroidism is not an emergency. Except in some special situations.
In fact, there is a sort of, based upon the TSH also, one can start the dose.
There are people have used different formulae. What I'm saying is that there is generally no need in most patients to start with, and if a 100 kg patient comes and they do come, I don't start with 160, even if he's young. I probably just start with 100 maybe, and and then see. So a bit of leeway is there. So this 1.6 is like an absolute number which is very often not applicable to our patients in the real world. And most of them are controlled at lower doses. So many of your patients will be controlled on 50 and 75 all the time. Most of them are controlled on those numbers. So
I fully agree with you. Then again, that all depends upon the what is the residual thyroid
yeah,
function is
absolutely.
also there. Well, if there are no questions, thank you very much.
Thank, thank you, sir, for your kind deliberation. So our next session is management of diabetic foot from bedside to bedside. And for this, we have with us today Dr. Ashu Rastogi. He is an associate professor of the Department of Endocrinology, PGIM at Chandigarh. He has published 145 research papers in index journals, including Lancet, Diabetes Care, and is also recipient of this research paper in IWGDF, Netherlands 2019, also recipient of several awards like Professor P.R. Srivastava Odishan, RSSTI 2017. So, Dr. Ashu Rastogi, please, you can start.
Yeah, thank you. And I'll be very brief because me and Kotwal sir have to catch a flight. So I'll just tell you what we have done and what three things that you need to know, what new advances are there. And these advances are related to from our research unit at PGI. This is the institute from where I work. And this picture you can see is from The Hague. That is a place from where every 4 year you have IWGDF guidelines. And I was just jogging on the shore of Hague in Netherlands where I took this photograph. It was from a soldier in World War II who lost one of the leg. And it's a huge bronze statue. But this shows the irony of our patients of diabetes who lose the limb. So this is about this. This is not working. Yeah, so this is what we know about the wound healing. It's a complex process, involves three major steps. One is inflammation, then proliferation and remodeling. And you'll be surprised to know that unfortunately, all of this is stuck up in a given patient of diabetes. So the wound is stalled. And what we need to do, we need to find some novel situations and novel formulations for wound healing. And one of the things that we worked upon is related to the novel molecule. We know about esmolol. It is a very short-acting beta blocker, which is available only in the parenteral preparation, and it is given in patients with heart failure or somebody who's having supraventricular tachycardias. So we just repackaged it in a topical formulation, and we did this in vitro, in vivo, and the ex vivo studies. This ex vivo we did fibroblast cultures, and in vitro we studied the aldose reductase and age inhibition with esmolol, because we know that advanced glycosylation end products can lead to the stalling of the wound or poor wound healing. And then we did a mice studies also in streptozotocin induced mice, and we applied this esmolol. So esmolol was used in a formulation which is 14%, and this was published in Frontiers. And this is related to showing how esmolol can work in a given patient of diabetes who is having a foot ulcer. So these are ex vivo results. It showed that esmolol improves the migration of fibroblasts, endothelial cells, and keratinocytes with esmolol. And in vitro result also showed that if you are using esmolol topically, it can improve the hydroxyproline content of the wound. And we know that with hydroxyproline, this is required for the wound closure. At day 14, the levels of hydroxyproline in the wound, when we took the biopsies from the wound, which was created in the streptozotocin-induced mice, it was quite significant. And this is regarding the endpoint clinical result in diabetic mice. The percentage of epithelialization in the diabetic mice was significantly improved. And by this preclinical study, we showed that a topical esmolol hydrochloride is a novel and a safe, effective treatment modality. It acts through multiple mechanisms that we have proven in the in vitro studies and ex vivo studies, and we concluded that human studies are warranted. So we went ahead with human studies, and we did this phase 1 and phase 2 study. It was published in Advances. This was related mainly to the dose finding of esmolol for topical as a topical preparation, and also everybody would wonder that if you're using esmolol, it can get absorbed into the systemic circulation and it can lead to the Brady's. So we measured the esmolol concentration also, and esmolol, when topically applied, had minimal systemic concentration. It was much less than the quantification limit. It was suggestive of that esmolol is quite safe for even human use
for patients of diabetic foot ulcer. So finally, we did this phase 3 study that we published in JAMA. That is a 27 center study, all sites across India. And this is related to the phase 3 use of topical 14% preparation of esmolol for healing of diabetic foot ulcers. And we took patients who were having UTS or University of Texas grade 1 ulcers that were non-infected, but they were non-healing even after proper treatment. And in these patients, this is the schema of the study protocol. All the patients were divided into three major arms. One was given the sham treatment or a sham gel. The other was given the standard of care only, and the last one was given esmolol in the topical preparation. And then these patients were studied. This was patients were randomized by WRS system, and both the nurse, the PI, and the patient were blinded for the treatment protocol. You can see this was a shield that was put on to the side of the patient so that he cannot see what is being applied on his foot. So by this, these patients were randomized and they were then seen for the efficacy outcome, and the efficacy outcome was proportion of the complete closure of the wound. And you can see this, the odds of wound healing was almost 2 times higher if a patient is given esmolol as compared to a sham gel. And this is also seen in those patients who have a different kind of wounds. You can see the patient's average wounds in India when they come to an institute like PGI, which is a tertiary care institute, it's quite old wounds. So this patient had a very old wound, but once this esmolol was applied, it leads to significant decrease in the size of the wound. And finally, at the end of the study, the patient had a significant wound closure that was seen. Then we also went on to study that what is the difference in the efficacy of esmolol if the wound is on plantar or a non-plantar site. And we found out that it doesn't matter whether it is on plantar or a non-plantar. The wound was beautifully healed with esmolol as compared to the sham gel. Same is with wound size. If you take wounds which are less than 5 centimeter or more than 5 centimeters, the esmolol has similar efficacy in wound healing. So this is again subgroup analysis because we know that there are many factors which can impair the wound healing like anemia, hypoalbuminemia, poor glycemic control. So we further sub-categorize these patients on the basis of anemia, without anemia, having albumin less than 3 versus normal albumin, having poor glycemic control versus normal glycemic control. And we found out that irrespective of whatever the patient characteristics are there, whatever is the wound characteristics, if it is UTS1 wound which is non-infected, esmolol leads to significant improvement in wound healing irrespective of that. So this is the final conclusion. And fortunately, this drug was patented, and this patent is now into the market for use for our patients of diabetes. So this is the outcome of the study, that with intervention, there is significant improvement in wound healing with esmolol. So this is the first part of the story, because I'll be very brief. Second part of the story is another interesting concept that has come up in the wound healing is about matrix metalloproteinases. So we should know what exactly are these MMPs. So MMPs are basically the enzymes that belong to this metalloendopeptidase family, and these enzymes are predominantly responsible for degrading the extracellular matrix. And we know that these extracellular matrix are required for wound healing because you require keratinocytes, you require fibroblasts, you require collagen for the wound to heal. Unfortunately, these are degraded by MMPs, and there are 4 different families of MMPs. So this is what happens is, in a patient who is having chronic wound, he comes to you that he is having non-healing of wound for past many weeks. So what is actually happening in the wound? So people have done studies and they have done biopsies of that wound, and they have found out that the level of MMPs in these wounds are very high. The matrix metalloproteinases, whether it is a pressure ulcer or diabetic foot ulcer, the MMP levels are almost 65 times as compared to a patient who is having an acute non-infected wound, and that is responsible for a lot of debris and non-healing in these wounds. So this studies which was done by Lazaro, which was published in Journal of Wound Care, showed that this increased level of matrix metalloproteinases are responsible for poor wound healing, and that's mainly the ratio between the MMPs and TIMPs. Remember, TIMPs are basically the tissue inhibitors of MMPs. So you need a good ratio of TIMPs and MMPs for the wound to heal. Once this ratio is biased towards MMPs and less of TIMPs, you will have a poor wound healing. And that happens in diabetic foot ulcers. and it's predominantly the MMP9 and MMP2 that is responsible for poor wound healing. So can we do something for matrix metalloproteinases? Can we inhibit this MMPs in the wound so that these diabetic foot ulcers can heal? So definitely it can be done. We have to rebalance the wound environment, and we have to definitely first should have a wound which is non-infected by giving proper care, debridement and antibiotics. And later on for the wound to heal, you can hasten it. And how you can do it? So this is the concept that was brought forward by Mike Edmonds from King's College London. And they use this sucrose octasulfate dressings, and sucrose octasulfate is one which inhibits the MMPs in the wound. And by decreasing the MMPs, it improves wound healing. This is also now available in India and we are using it. So they have found out that using sucrose octasulfate effectively heals the wound by reducing the MMP levels. So this is a TLC NOSF technology. This was published in Lancet way back around 5 years back, and they showed that you can have 60% more number of patients can have wound healing if they are having UTS 1B ulcers or 1A ulcers. More importantly was the number of days taken for wound healing, because now that is responsible for poor quality of life. More the number of the days patient is having or having the wound, it will lead to poor quality of life. So there was 60 days less which is required for wound healing if the patient is using these MMP inhibitors or sucrose octasulfate dressings. And percent of wound which is completely healed after 20 weeks of treatment was significantly more. Whether the wound is of less than 2 months duration or it is very long standing wound of more than 9 months, these octasulfate dressings are very good. I'll just show some cases in our unit. This was a gentleman, 74-year male, who had a duration of foot ulcer of 13 weeks. A1C was relatively good control. X-ray was normal. He was having this wound which was on the heel region. He was not having any kind of osteomyelitis. Sharp debridement antibiotics were given. Then the NPWT or VAC was given. And after that, the patient was started on NOSF dressings, and you can see the wound beautifully healed after 14 weeks. His A1C at the end of this duration was 6.7% with good glucose control as well. Another case of 45-year female, duration of diabetes 11 years, wound of 13 weeks, poor glycemic control with having a normal ABI of 1.1 and 1.1. She was started, she was already had an amputation of the toes, and on that toe, that wound was not healing. She was given this NOSF dressings, and after 6 weeks, the wound beautifully healed. His A1C was also controlled, and his fasting, her fasting and BP was also controlled. Same, another patient who had a very large wound with poor glycemic control, who was again given the NOSF dressings after appropriate the infection control, and the wound nicely healed after the 6 weeks. This is the last part of my presentation. Sorry for going very fast. This is again that we have developed in our institute. This is a very novel modality for understanding or knowing which of your patients can have foot osteomyelitis, because problem is that whenever we see a patient of complicated diabetic foot, and by complicated I mean he's having CKD, he's already having a deformed foot, he's having Charcot foot, on top of that he develops an ulcer. So in few of our patients you have to rely on some nuclear scans, and nuclear scans definitely not for all patients, but in some patients who have very complicated wounds, when you are suspecting that this patient is having deformity, Charcot's, on top of that an ulcer, and you suspect osteomyelitis, what you can do. So we did this study. This is related to the labeled WBC FDG PET scans for the diagnosis of the diabetic foot osteomyelitis in patient with Charcot's. I presented this way back around 8 years back in San Diego in US Endo meeting. And this has also come up in the IWGDF guidelines as one of the modality for diagnosing diabetic foot osteomyelitis. I'll just describe how does it work. What we do is we take just around 20 ml of patient's blood, we isolated WBCs from the patient, and we tag them with FDG. And this FDG labeled WBC are then re-injected into the patient. So these WBCs go to the site of infection. Another scan we tag it with is a F18 scan, and we know that F18 binds predominantly to the hydroxyapatite of the bone. So by having a combined scan of labeled WBC and F18, we have a tracer that goes only to the site of infected bone. So this is how it works. In this patient, you can see that he had already lost 4 toes. Unfortunately, he came to us with a single toe left, and on top of that, he had a wound over the first metatarsal head. He was very possessive. Doctor, please save my this toe, I don't want to get it amputated. Our problem was how to die. He was having CKD. Our problem was how to diagnose osteomyelitis in this patient. Definitely, the X-ray was normal. We did bone culture; it was suggestive of Pseudomonas aeruginosa. But once we did F18 labeled WBC, you can see in F18 multiple bones are being seen which are bright. That is suggestive of increased uptake in multiple bones, suggestive of some kind of Charcot's pathology or degenerative changes. But the labeled WBC is going only to the site of first metatarsal head, suggestive of osteomyelitis. So this is an evidence of true positive, but true negatives can also be seen. In this patient, he was having a deformity and he was having a navicular bone which was popping out, and he was having an ulcer over that. We were thinking that it can be osteomyelitis. So what we did again these kind of scans. The first scan is an F18 scan which showed multiple bright bones. It was suggestive of Charcot's, acute on kind of a chronic Charcot's. But once we did labeled WBC, you can see the arrow is showing only on the soft tissue. It's not showing the bony involvement. It suggests that it is a kind of a true negative scan for a diagnosis of osteomyelitis. So we proved that this modality is 100% specific for the diagnosis of osteomyelitis, and you can use in very small subset of patients who have complicated foot and have a complicated pathology in your patients. So I just wanted to show these three modalities that have come up recently where we have worked up, and now all of these modalities are in the guidelines when we can use these modalities for healing of foot ulcers. Remember that these ulcers are really very difficult to treat, very difficult to heal wounds, but topical esmolol has been found to be efficacious in non-infectious UTS1 wounds, and high matrix metalloproteinases definitely lead to poor wound healing. We can inhibit it by using sucrose octasulfate dressings, and in few of your patients who have some diagnostic conundrum, you can use the label WBC for the diagnosis of DFO. So thank you.
Thank you. Thank you for your excellent deliberation. So I would invite some questions from audience now, if there is any.
Ashu, in the Esmolol series, did you do a skin biopsy?
No.
No. And
We did skin biopsies only in in vitro preclinical studies, not in phase 3 studies.
okay. And do you have any clue as to any possible impact of esmolol on matrix metalloproteinases?
Yes, that was the food for thought. Once we were going ahead in the phase 3, once we completed phase 1 and phase 2, we wanted to do the phase 3, but we didn't get the appropriate funding for MMPs. But we are now planning to do MMPs also. I believe that esmolol might also inhibit MMPs.
Thank you.
Thank you, sir.
And Dr. Rastogi, I had some experience of problematic diabetic foot ulcer in spite of best efforts, all ended in a fiasco. Then, to our surprise, we found that there was nerve thickening and there which was not properly taken care of. Then we did a biopsy study and we found that there was leprosy. So diabetic ulcer and leprosy induced ulcer, they frequently coexist. Then anti-leprotic treatment and all the necessary diabetic foot ulcer treatment were started and ultimately the ulcer healed. I found two cases in my medical college stay, and this is number one. And number,
May I comment over this?
yeah,
Yeah. So you'll be surprised that we also see leprosy these days, even especially in tertiary care institutes, and we run a leprosy clinic with Department of Dermatology in PGI. And I am more working on how leprotic Charcot's is different from diabetic Charcot's. Because leprotic Charcot's is purely neuropathic Charcot's, and diabetic Charcot's is neuropathy with hyperglycemia. So we are taking bone biopsies of these patients and want to understand what is happening actually, what is different. So you're absolutely right. Leprosy can also present with neuropathic ulcers.
yeah. So that's a very nice piece of information. Again, in the diabetic foot ulcer, there is bone remodeling in favor of some increased osteoclastogenosis. So in that scenario, bisphosphonate has been recommended in some study. So what is your take on this?
So I presume that you're talking about Charcot's foot. So we and others in the world have published RCTs over bisphosphonates in patients with Charcos. None of the bisphosphonates, whether it is first was experience was with palmidronate from Edward Jude in Manchester. Second was with the zoledronate, that was a Dutch study. And then we did study with zoledronate again compared with methylprednisolone. But none of the studies have shown that it improves outcome of patient with Charcos. Neither it reduces the time in cast or total contact cast for these patients. So, and then we published a meta-analysis collating all the studies in the world related to bisphosphonates, and it showed that it increases the time to remission rather than decreasing it. So from 2021, when we published this meta-analysis, we have stopped using any kind of anti-resorptive therapy for Charcot foot.
Thank you.
So if there are no more questions, we can end this session now. Thank you, Dr. Rastogi, for your insights. So for next session, the next session is about type 1B diabetes, reality or myth. So for that, we have with us Dr. Riddhi Dasgupta. Dr. Dasgupta is an associate professor in Department of Endocrinology, SIM, SRC. He has many achievements. He has got fellowship in islet cell transplant from Newcastle, UK, and also a fellowship in obesity metabolism from Cambridge, UK. He is recipient of Anil Arshet Award from Endocrine Society of India in 2019. He is also recipient of Novartis Young Investigator Award RSS from RSSTI in 2019. And he has more than 60 publications in national and international index journals. So, Dr. Dasgupta, you can start with your session now.
Good morning to all of you. First of all, I would like to thank Team Crescendo for the wonderfully organized event and for having me here. So I have been given a rather debatable topic today of whether type 1 diabetes is a reality or myth. And since I am the only speaker, I will try to look at both sides of the coin. So why the confusion? Obviously, if you look at the classification, 1997 was first when ADA proposed the terms of type 1A and type 1B. Over the years, that has been replaced in the 2024 classification. The 1B has become known as the idiopathic type 1 variety of diabetes, meaning the roots are not quite clear. Whereas the WHO 2019 has been quite categoric in removing these two subtypes of type 1 diabetes, and they treat it just as simple type 1 diabetes. And of course, as you know, more and more we are finding subtypes of diabetes leave groups publication as also increasing evidence that there is significant overlap between the subtypes, and we may need to move out from the traditional thinking of type 1 versus type 2. So, to consider first that type 1 diabetes does exist, it is a reality. What do we need to prove? We need to prove that it is indeed a form of immune mediated diabetes. However, it's an immune mediated diabetes with low autoantibodies. So, why that? And does it have a clinical course which makes it distinctive from the very common type 1A variety of diabetes? So coming to the first question, as you know, this is the very well studied model of type 1A diabetes, and you can find the beta cell autoimmunity playing a major role. However, that brings us to the question, if you look at the pathogenesis of type 1, it is mainly the T cell mediated process which takes charge. And in effect, when we say that a patient has antibody positive diabetes, what we are trying to signify is that it is merely a manifestation of the underlying T cell response. So, unless we are able to track that T cell response, unless we are able to find manifest evidence of that, it may be inappropriate to label a diabetes as immune negative just on the basis of autoantibodies being negative. The other important factor that we often overlook is the increasing role of HLA. As you know, it plays a very significant role in most type 1s, and HLA typing for these antibody negative, so-called antibody negative type 1s, may actually prove to be a pointer to the underlying immune mechanisms. And as these studies have shown, there have been strong links with genotypes, HLA genotypes, even in those with autoantibody negative type 1 diabetes. Again, as I said, it would be ideal to assay the T cell biomarkers like CD4 and CD8 plus T cells or the helper T cells, and there has been clearly studies that have shown inverse correlations with fasting serum C peptide and the T cell biomarkers. Unfortunately, the assays for these are notoriously labile and not equally applicable across the spectrum. So that limits our understanding of the disease. Now, coming to the question of why are antibodies low? Now, multiple factors have been proposed for this. One, again, is the HLA pattern. So these have more of the protective HLA pattern as opposed to the high-risk HLA pattern, which prevents the autoantibodies from being manifest. CD20 cells. Now, this very interesting study looked at people with type 1B, supposed 1B diabetes, and they divided into those with higher CD20 cells versus lower CD20. And it was found that the CD20 cells can influence your autoantibody positivity. So if you have low CD20 levels, you may actually end up showing lesser autoantibodies on the test, despite having an immune-mediated variety of the diabetes. Age at diagnosis, again, multiple studies have shown if you're having the disease at a slightly older age, like more than 13 or 14 years, then your propensity of having a lower CD20 and lower autoantibody automatically increases. Similarly, ethnicity. Two very major studies, one from the UK Biobank and the other from Asia, has shown that up to 25% of the children assigned type 1 are negative for all the three autoantibodies, and this is directly related to being belonging to a white versus a non-white population, despite having the T cell markers for autoimmune diabetes. Again, antibody deficiency has been studied, and up to 2% of people, 1.5 to 2 in the European cohort, with common variable immunodeficiency have been found to have this variety, which has been labeled as the 1B diabetes. Coming to the question of the clinical profile of type 1B diabetes, obviously, it is different. This study from UK across a large number of patients have shown that they are characterized by a higher BMI and greater C-peptide levels as opposed to that of 1A diabetes. Similar studies done in more than 3,000 people, including pediatric patients, have also shown almost similar results where older age, male sex, and non-European ethnicity have been found to be major factors determining your antibody positivity. Not only that, the type 1B has a more slower rate of beta cell destruction and continue to have higher C-peptide levels over a period of time, thus creating a diagnostic confusion. Uh, Similar studies done in pediatric age groups have also shown that despite the presence of high-risk HLA being detected, the C-peptide levels persist to be higher, lower risk of diabetic ketoacidosis, and hence often misdiagnosed or labeled as type 1B diabetes. Another large database has shown that despite having lower insulin requirement when compared to the type 1A group, these actually end up having a higher CV risk, possibly because of the higher BMI, obesity, and other factors that are seen in this group. So if these are antibody negative and have the protective HLA risk factors, what actually drives the beta cell failure in type 1B? So this is the very well-known accelerator hypothesis, which says that in this group, possibly insulin resistance and not insulin secretion defects should be kept in mind. And as you can see, people with single autoantibody positivity and obesity-like phenotype have a much earlier manifestation of diabetes than those which do not have the obesity-related factors. And as you can see, as the age increases, the obesity-related effect on the beta cell loss takes an upper hand over the autoimmune processes, further justifying why, despite the negativity of the autoantibodies, they have the slow loss of the beta cells over time. A similar study which has shown that autoantibody negativity and people with single autoantibody positive may have similar mechanisms mediated by the insulin resistance. So now coming to the other side of the coin, if we assume that type 1B diabetes is a myth, it's a misclassification, then we have to look for other atypical forms of diabetes that can actually be confused with this. And we need to look at what are the distinctive features of these form of diabetes. And in an Indian scenario, if there are data or if there are reports to suggest that this variant is actually important for our patients. So this is a very interesting graph which shows the different diseases spread out across the spectrum of insulin resistance as also insulin sensitivity. And when we are faced with a typical patient with antibody negative, insulin requiring, young onset, these would possibly be some of the differentials that have the risk of being misclassified as type 1b diabetes, ketosis prone diabetes, monogenic, of which MODY is the most common one, FCPD or type 3C, a bit about severe insulin resistance syndromes, malnutrition modulated diabetes, and rare genetic forms. So I will just take you through a few cases that I have come across and few studies that I have been associated with over the years that have looked into these various misclassified forms of type 1b diabetes, so to say. So this was a gentleman which we encountered in Vellore, a 30-year-old man with a BMI of around 25, came with frank diabetic ketoacidosis, managed as such autoantibodies negative. Once we discharged the person, he had progressive reduction in insulin levels, and C-peptide levels done after resolution of glucotoxicity began to show a remarkable rise over time. And at 3 years follow-up, he maintains normoglycemia on metformin with the C-peptide levels more than 3. So this definitely is the variety known as flatbush diabetes or ketosis-prone diabetes. And this is an overall view. As you are aware, it presents explosively with decay like type 1, and then over time there's a rapid reduction of insulin requirement. Now, till 2017, it was not reported from India. After we got the index case from Vellore, we tried looking at our database, and what we did is we did a prospective study of all patients who were admitted with diabetic ketoacidosis over a period of 2 to 3 years, and we reported the first cohort of around 25% of people with new onset DKA who were being misclassified as type 1 diabetes, and these were actually the unprovoked variety of A minus beta plus ketosis prone diabetes. Almost 4 years later, I was working at Durgapur, and there I found this 32-year-old lady, similar presentation, BMI of around 25, diabetic ketoacidosis. The only difference was it was the time of the pandemic, and she was positive for COVID. Once everything settled down, she also started showing a remarkable recovery in her C-peptide levels and beta cell function. So this made us think that is there a provoked variety of A minus beta plus KPD, and is that possible in an Indian setting? So when we looked at literature, indeed, provoked KPD has been reported previously with H1N1 influenza outbreaks and human herpes virus 8. We followed a very similar pattern of profiling C-peptides and progressive insulin secretion over a period of 1.5 years in these patients, and we found that up to 30% of these were actually provoked ketosis-prone diabetes. Once again, the first reported cohort of COVID-19 associated KPD from India. Coming to the pathogenesis, these very elaborate studies by Patel et al. Have shown that there are key defects in branch chain amino acid metabolism and defects in ketone oxidation, which drives that. We looked at metabolomics in a very limited set of 8 patients from our Velo data and found similar patterns of accelerated leucine catabolism and defective ketone oxidation in our group of patients as well. Coming to the next patient, asymptomatic spina bifida, 16-year-old boy. The diagnosis is pretty obvious, posterior urethral valve, severe hypomagnesemia. So this is a classical presentation of an HNF1 beta, once again showing a MODY5, which masquerades as a possible type 1b diabetes. Important to remember is that the criteria for MODY has undergone revisions over time, and currently the requirement is for at least one first-degree relative, and the age is pretty flexible between 30 to 35 years. Among the subtypes of MODY, I would like to point out these which can have severe insulin deficiency at presentation, and even the ones like PAX4 have been reported with diabetic ketoacidosis. So it is wrong to assume that all MODY would be just managed on gliclazide or glibenclamide in your clinic. Again, studies from Vellore have shown a very distinctive pattern of MODY consisting mainly of neuro D1 and PDX1, and similar studies have been done by the group of Dr. Mohan and colleagues. So can we predict MODY? Again, now this is freely available. Exeter has launched a very easily available app by which you can actually calculate the risk of MODY in these unclassified or idiopathic patients, and it is free to download. A 24-year-old lady coming with diabetes since age of 22 years, managed again with insulin. On examination, had acromegaloid features, macroglossia, virilization with complete loss of fat, subsequently found to be a form of congenital generalized lipodystrophy. A similar presentation of a mother-daughter pair coming with severe uncontrolled diabetes managed with insulin, Cushingoid face and acanthosis. And this is again on genetics, we found to be a familial partial lipodystrophy. So lipodystrophy group of diabetes, once again, which forms under the broader category of severe insulin resistance syndromes, can present in the young age with severe insulin requirement, and those can often be again misclassified as type 1b diabetes. Again, there is a subgroup which acts at the level of the insulin receptors, and these actually have preserved adiponectin. These are mostly found in children, and you have the spectrum of either a Rapson-Mendenhall or a Donahue syndrome. Now, this is a 28-year-old gentleman, again, history of osmotic symptoms, sensory neural deafness, WPW syndrome on ECG, injectable insulin used. So this is a form of mitochondrial diabetes, and we detected the typical A3243G mitochondrial DNA mutation. A 22-year-old boy born out of consanguineous marriage, diabetes since age of 7 years on insulin, bilateral optic disc pallor with neurosensory deafness and neurogenic bladder. Once again, the diagnosis clinically was pretty obvious. This is a case of Didmode or Wolfram syndrome. Interestingly, there are two important publications from India that have come out. One by the group of Ish Bhatia et al., which suggests that there is 25% of insulin antibody negative type 1 who had the recessive WFS1 mutation, and this one again from Valor, which identified 3 novel variants in the population which are antibody negative. A 26-year-old male, recurrent abdominal pain, managed with insulin from the beginning, also complained of night vision for 1 year, which was largely neglected. On examination, we found bilateral whited spot, typical appearance of vitamin A deficiency and calcifications of the pancreas, suggestive of an FCPD. Especially in the setting of an Indian context, this disease is very, very important because most of them go around being treated as type 1 diabetes without a proper abdominal imaging being done previously. We thought of looking at two very unknown facets in this group of patients. One was insulin resistance, and the other was the role of glucagon, which has not been looked at before. We performed elaborate hyperinsulinemic clamp studies in around 50 patients and calorimetries, and also NMR SPECT to look at their fat composition. And we found that FCPDs, along with insulin secretion defect, have very significant hepatic and peripheral resistance. And what was the most striking fact was a significant rise in glucagon, both in the fasting as well as the postprandial state, which was much higher than the type 1 and the normals. So we thought of why should FCPD patients who are known to have complete pancreatic destruction end up having high glucagon? What could be the possible source of this? So firstly, we looked at patients with hypoglycemia awareness because that is one of the hypotheses proposed, that because of lack of glucagon, they're more prone to that. And we found there's a distinct dichotomy in the FCPD population, and hyperglucagonemia actually protects them from significant hypoglycemia unawareness. Moving forward, we performed these studies, which are known as the IIGI or the isoglycemic intravenous infusion test. And by this study, we looked at the various gut hormones, incretins, and glucagon secretion. And this was based on the work by Lund et al., which first showed the possibility of extra pancreatic glucagon secretion in man. And our studies suggest that possibly the L cells of the gut are the source of the hyperglucagonemia in patients with FCPD. So this is something which is currently under review for publication and opens up very exciting possibilities for future therapies. We also looked at the incidence of decay because this is another saying that because of the lack of glucagon, there's a difference in the decay presentation. And we found that there are also people who are prone to diabetic ketoacidosis in FCPD. We found a rate of around 8 to 10% have higher glucagon levels than the FCPDs, which do not end up having diabetic ketoacidosis. Moving to the last variety, that is the malnutrition modulated diabetes, which incidentally the classification has been taken out by WHO, but at Valor we have been working on that for quite some time. And this typically again presents in a very low BMI individual, largely insulin requiring age group of around 25 to 30 years or slightly older. And there is growing evidence of malnutrition modulated diabetes from India. We have performed studies across low birth weight cohorts as also NMR SPECT studies. And we also looked at hyperinsulinemic clamps in this group of population, and very distinctive pattern, completely separate from the type 1 or type 2. Despite their very low BMI, we found a significantly high pancreatic fat, which was one of the surprises for us, heterogeneous insulin sensitivity, and a remarkable loss of insulin secretion. A marked insulin secretion was seen across the spectrum. We also formulated two new indices, the SPINA-CARB and the SPINA-D, which we feel moving forward should be used for insulin sensitivity categorization in this very unique form of low BMI diabetes. So to summarize, definitely the clinical spectrum of a person resembling type 1B diabetes coming into your clinic, autoantibody negative, low C-peptide, requiring insulin is very much a reality. We find it quite commonly in our patients. But is it a true immune-mediated diabetes, or is it some differentials that we need to consider? For that, this is a something which I just kind of made on my way here. So we need to look at certain factors like weight, age at diagnosis, T cell population, C peptides, HLA, family history of type 2 diabetes, ultrasound or associated features, especially for MODY or FCPD, and finally your ethnicity. So once you subject these patients, this population to the watchful criteria, you need to be judicious in the use of tests. In resource limited settings, again, I think C-peptide can be one of the very important tests that can help us, along with some basic tests like ultrasound imaging and awareness of the clinical features that these patients may have. Thank you.
Thank you, Dr. Dasgupta, for your excellent deliberation. So at this point, I would like to invite some questions from audience.
Well, Riddhi, congratulations. That was a thought-provoking talk.
Thank you, sir.
The point is, having acknowledged the mimickers of antibody negative insulin requiring diabetes in young, we too also have a cohort of patients who are antibody negative but behave phenotypically like type 1. They are lean, they are insulin requiring, they are brittle. So my thinking, or what do you think on it, is it a spectrum disorder? Is what we are calling type 1B diabetes is indeed an autoimmune diabetes, but somehow we are failing to pick up the autoimmunity because the antibodies have become negative a bit too early. Why, I do not know. Rather than a MODY being missed, that can definitely happen, or a type 3 diabetes being missed, but in majority of cases, they by and large behave as type 1 diabetes. Maybe, as you said, the insulin requirement may be a little bit different, but is it a spectrum disorder? What do you think?
Yes, I think as I showed the pathogenesis, I would say there is a difference between saying antibody negative type 1 and non-immune diabetes. These two are not synonymous. So that's the first thing that we should understand. If we have to label the patient as a non-autoimmune form of diabetes, we need to look at the proper mechanisms which guide it, which are the T cells, which unfortunately are not that easy to assay. There are certain flow cytometric methods which have come out, but it's not standardized. HLA, again, I think if you are trying to label someone as a misclassified type 1B diabetes, or you want to say that this patient doesn't have a type 1 diabetes, autoantibody negative, HLA typing should be mandatory. Without an HLA typing, we should not be labeling someone as non-type 1. So in a lot of cases, we do not do that. But thing is that once you do the HLA, as the studies have also shown, that there is significant amount of HLA influence in people who have Again, the second important thing is the age at which you are seeing the patient. So if you see the patient at an age of less than 7 years or 10 years, as opposed to someone, same patient comes to you at the age of 20 or 25, the autoantibodies by the processes I discussed may have come down or may have been at such a low level that it's not picked up. So basically, you're seeing the same disease at two different time points. Amongst the differentials that I discussed, I would say ketosis prone diabetes is probably the closest that would go to type 1B diabetes. The others like FCPD, MODY, lipodystrophy in a proper setup should be we should be able to pick it up either from the history or clinical examination or test. But ketosis prone diabetes, unless you do serial C peptides, unless you follow up the patient, it's very, very difficult with the first visit or the first two visits. And even if you look at the largest data on ketosis prone diabetes, 60% of them actually have gone on to require insulin behaving like a type 1 over a period of 5 to 6 years. So I think that is the challenge now with the growing data that KPD is a reality in India. Whenever we get a patient behaving like type 1, DKA, low C peptides, I would suggest to repeat C peptides at 6 monthly interval just to be sure that we are not missing out on that proportion of ketosis prone diabetes.
So if there is no more questions, we can end the session
Thank
now.
you.
And just a small announcement, the participation certificates are ready at the registration counter. So the delegates and faculties are requested to collect their certificates from the registration counter. So for the next session is about primary adrenal insufficiency. And for that, we have with us Dr. P.K. Jabbar. Dr. P.K. Jabbar, Professor P.K. Jabbar is a professor and head in the Department of Endocrinology in Government Medical College, Trivandrum. He is also a director and CEO in Indian Institute of Diabetes, Trivandrum, India. He has more than 70 index publications. So over to you, sir, for your next session.
Good morning, everyone. Respected senior members of our society, Dr. Ambarish is there, Dr. Nilanjan, and Dr. Lot of important personalities are sitting over here. I bring regards from God's own country, Kerala state, and special thanks to team Endocrine Society, West Bengal chapter for the invitation as well as hospitality. My dear friends, my topic for today is very simple and straightforward, but lot of complexities which are not included here because two reasons. Mainly, I thought this discussion would be for physicians and lot of time constraints also there. So I'll be discussing few cases here, and I'll discuss one or two papers which are published from our Department of Endocrinology, Trivandrum Medical College. My dear friends, if you are discussing a topic, it's very important to remember the doyens in the field of the subject. So if you see that Thomas Edison, in the left side, you can see this photograph. He described, and three important personalities also I have projected here because we should not forget the contribution of those personalities. And with the discovery of these medicines, we got 3 Nobel Prize also in this field. Please remember. And lot of things are happening. Lot of things and certain things are totally dream for the time being, but lot of works being done in the field of Addison disease. Let me start with my case. Very simple, straightforward case happened in Trivandrum Medical College. We have a patient. Patient problem was, patient is having severe prostration, especially if patient is having some sort of stressful event, maybe simple febrile illness, or maybe because of simple or overwork, something like that, in a setting of a autoimmune thyroid disease, and this patient is getting little bronzing or hyperpigmentation, gradually it's worsening. And one fine day morning, this patient is coming to casualty, medical casualty with the features suggestive of adrenal crisis. Thanks to God and applause to residents who were sitting in the casualty. He thought, he will go for cortisol essay. It was very positive and referred to endocrinology department for the evaluation. My dear friends, this was the picture 5 years back. It's a Mallu patient. You can see the fair complexion and subsequently patient complexion has changed to dark or see probably like so bronzing something like that, and you can see what's happening with the other areas also. Look, significant hyperpigmentation was documented in this patient. If you look at the adrenal failure or primary adrenal insufficiency endocrine society recommendation, pretty old, but it's very important. You can't go for cortisol assay for all patients with the non-specific symptoms. Very interestingly, there are papers saying that it's a 42% of the patient, 42% of the patient, their diagnosis missed in our clinical practice, delayed diagnosis. But see, if the patient has got multiple symptoms like this, see, like says minimal hypertension, hyponatremia, minimal hyperkalemia, such a situation you can ask for investigation. Don't go for high-tech investigation. Examine the patient and think about the differential diagnosis also. Don't take a message that so all these bronze case or hyperpigmented case are having Addison disease. It's not true. There are 1 dozen of differential diagnosis for primary adrenal insufficiency. Please remember that. And having suspected the possibility of adrenal insufficiency, what is investigational choice? Simply you go for basal cortisol. Again, very important challenge here. Yeah, there are doyens sitting in the field. What is a cutoff for diagnosing adrenal insufficiency? Is it 3? Is it 2? Is it 5? Still controversial point. There are certain evidence for each figure also. But if you take the Bible, Endocrine Society Bible, the exposition statement, what they feel that if the patient has got a cortisol, basal cortisol less than 5 microgram, plus elevated, at least twofold elevation of ACTH, that clinches the diagnosis of Addison disease. Of course, if you have facility, you can go for synactin test or actin test also for confirm with the diagnosis. Synactin, I'm not taking a lot of time for that. It's very simple to proceed, but there are limitations for doing synactin test, mainly because of the availability. And of course, if you want to discuss the factor of cost, which is also very important, especially certain parts of the world. Now, if you are performing ACTH or synactin test, what is the cutoff? When we look into all these references given the lower panel, what is written, the sensitivity of synactin test, and it's around 92 percentage if you take a cutoff of 18 microgram per deciliter. So if you give synactin and if you document a value above 18, that is diagnostic of adrenal insufficiency. There is no doubt about that. And very clearly they have written, see, if you have facility, you can go for synactin test, and values very clearly mentioned there. And they emphasize the importance, if the synactin test is not available, go for cortisol and ACTH level also for documenting Addison's disease. And now see little extra. See, there are people thinking that the cortisol, you have good assays. When I was a student, the assay system was not very good. Now people are using LCMS also. Such a situation, you should reduce the cortisol cutoff. This is one paper saying that if the basal cortisol is less than 2, is predictive of a good yield if you are going for a synactin test. What is the cutoff? See, just look into the second or third panel, 18 micrograms. And if you are using various platforms, just simplify the machines, the cutoff is slightly different. So there are papers say that 14.5, there are papers say that 14.6 and 8, something like that. One take-home message from this slide is very simple. Now, cutoff is changing in our clinical practice for diagnosing adrenal. So that's a take-home message. Now, I told in a cost is a major risk factor for assessing the adrenaline insufficiency. Such a situation, you can go for Actum or long-acting opposite ACT, which is freely available and very cheap molecule also for diagnosing adrenaline insufficiency. I'm not discussing in detail, but it's not a new idea. This idea came up in Endocrine Society journal also. In the absence of synactin, you can use this person ACTH for diagnosing adrenaline insufficiency. When we looked in the paper again, there are a lot of papers from India which showed this an alternative for assessing adrenal status in patient with the adrenal problems. This is one paper from Delhi which showed this is probably one of the earliest paper in human, and they did not look into the gold standard, that is synactin test. With this background information, we thought on a bill for the assessment of ACTH or ACTM in patient with adrenal insufficiency. This is our paper. We have included around 20 plus 27 patients with adrenal insufficiency. These are our observation. Our observations you can see here on the right side, mid-zone, what is shown here without adrenal insufficiency. Basal, as you can see here, so 60 minutes, the cortisol is, classical test is 20, and with the Actum is 22.6. So it was not statistically significant. With adrenaline insufficiency, what is shown here, the 60 minutes, you can see 9.3 versus 9.8. So that indicates this, the investigation useful. We have our own normative data by looking into the cortisol level, also with the ACTH, which is also published in the literature. So what I want to tell you that, see, you can go for 1 hour, and what we could achieve from our data, it is published here, see, after 2 hours, the value of 19.5 microgram per deciliter has got very good sensitivity, and moreover, see, if you are taking the level slightly lower down, 16.9, and sensitivity is improving. My dear friends, so what I want to tell you that this Actum is an alternative for assessing adrenal reserve, adrenal status in patient with the suspected disease. Now, coming back to our patient's data, so patient is a lady, and glycoside, see, hemoglobin is only 11, and sodium slightly on the borderline, potassium slightly on the higher side, and now other contributing factors from routine assessment. And patient cortisol, you want to get a level less than 5 micrograms per deciliter. For our patients, value is 2.76 micrograms, and patient ACTH was quite high to a tune of 435 picograms. So that clinches the diagnosis of primary adrenal insufficiency or Addison disease. My dear friends, you will get the diagnosis by simply looking to this investigation. Of course, you can look into the other zones also. There are 3 zones or 4 zones for adrenal gland: glomerulus, fasciculator, reticulator, and medulla. So you can go for renin and aldosterone also, if possible, if feasible, and if the cost is not an issue. And with this, we thought we'll go for imaging also. There is battery of investigation to find out the etiology or cause of Addison disease. Most of the investigation is not possible also, but whatever did you can follow and you can do in your hospital also. Imaging is also essential because certain infiltrated diseases which can produce adrenal insufficiency, which was reported as normal. So with this background of autoimmunity, hypothyroidism, autoimmune thyroid disease with a normal gland, we presume that this patient has got a primary adrenal insufficiency, basically or probably an autoimmune etiology. That's final diagnosis. So these are the highly exhaustive list for adrenal insufficiency etiology or causes, and this approach is given the textbook. If you can follow this, you can follow, but possibly it's not very much feasible in our clinical practice, but you can. What is the treatment of choice? Treatment of choice, again controversy. Is it hydrocortisone? Is it prednisolone? Is it dexamethasone? One sentence you can give, dexamethasone is not preferred. And let us see what's happening with the dosing of hydrocortisone. I prefer, if possible, I'll go for hydrocortisone. And there are a lot of papers saying that you can use other alternative drugs also like prednisolone. There is no doubt about that. See, if how to give hydrocortisone, just look into the physiology again. Physiology, the production is around 8 milligram per square meter and around 10 to 15 or max 20 milligrams of hydrocortisone in divided dose. That is the usual method of substituting steroids for our clinical practice. Now, single dose hydrocortisone is not at all suitable. Probably patient will go for issues and is not advisable. At least you can go for 2 doses of hydrocortisone, 1 dose in the morning and 1 dose probably after lunchtime also. This is 2 papers. This is quoted here, PAC and Hewlett. What they feel that is better for a good outcome, for good pharmacodynamic efficiency, you just go for 3 doses, 10 milligram with morning and 5 milligram at the lunchtime and 5 milligram probably somewhere around 5 o'clock or 6 o'clock. That gives a good profile, steroid profile like this. You can see here. And this is another data shows, simply or blindly you can't give steroids. Look into the weight of the patient, then calculate the dose of hydrocortisone, give, then only you'll get good steroid profile without producing over treatment or under treatment. This is the people are doing this paper is Ekman paper, which showed even you can go for 4 doses of hydrocortisone. People are thinking like that. Is it possible or feasible? I don't know. Basically, I don't think it's very useful. This is yet another turning point. See, Kerry Meeran's data, but he says that, see, you are giving excess dose. Start with probably 3 to 4 milligrams of prednisolone. That's more than enough. And what he feels that, see, you have to give. It's not his feeling. Always we should give fludrocortisone also, because our aim is to reduce the side effects due to hydrocortisone, cortisol. So fludrocortisone is needed. And yet another observation by Kerry Miran is, see, there is no effective method by using insulin pump also. This is yet another paper published after, I think, 3 years back, which showed prednisolone. In my era, probably Ambarish sir might have used lot of cases prednisolone for his patient also. At least I was very happy with the prednisolone. And of course, still now I'm using hydrocortisone. So these papers say that a prednisolone treatment is safe and very effective alternative hydrocortisone. So we are using lot of this prednisolone for our patients. How to monitor? Don't go for high-tech investigations like ACTH, renin and all, which I am not doing. We look into the clinical profile. If the clinical profile is okay, that's good. Like, weight gain, and always look into the insomnia. You have seen patients, especially if they're taking after sunset, they're developing little insomnia. So all these simple points will give the, say, assessment of sufficiency of medication. Now, this was the picture, and almost like this. Okay, so the patient improved like anything. So it's very useful. This prednisolone treatment was very useful and it's a treatable cause. But if you are missing a case of Addison's disease, that patient will die, because we had a very bitter experience in our casualty. Given beautifully discharge summary has written, do not stop steroids. Do not stop steroids. Fortunately, because of some febrile illness, she could not take it. She missed it, and she came to our hospital as product. So, for heaven's sake, proper education is also essential for patient with the Addison disease. This is yet another paper. This patient has got multiple features suggestive of Addison disease, like hyperpigmentation, and patient was having picture suggestive of classical Addison disease, and patient was little anemia also, hyperkalemia and hyponatremia. And you can see the value, very low levels of cortisol to a tune of 1.6 microgram per deciliter with elevated ACTH. And you can see there are a lot of causes for Addison disease. Making a diagnosis of Addison disease is not sufficient. Always look for the etiology of that. When we look to the history, this patient has got lacrimation problem. This patient has got a the dysphagia-like phenomenon. And finally, our team did a beautiful work for demonstrating achalasia cardia and autonomic neuropathy for this patient. Very simple for postgraduate students. It's a case of multiple issues, Addison disease, lacrimia, and achalasia cardia and autonomic. You can call it as for a syndrome with the steroid-induced diabetes because of the lacrimation. Someone was using high dose of steroid also. This is yet another problem case. This happened in Sri Chitra in the Tirunal Medical Sciences. What they showed, patient has got adrenal insufficiency, and patient subsequently developed seizure also, and they could document classical adrenoleukodystrophic syndrome in this patient. My dear friends, lot of things are happening in the field of treatment for adrenal insufficiency. You can just discuss certain terms here just for the completion, and people are trying to use insulin or pump system also for giving proper steroid profile. Of course, is really useful. I do not know, but I want to emphasize one important thing: proper education to the patient. If the patient is taking steroids, my dear friends, ladies and gentlemen, always think about the possibility of crisis at any time, especially if the patient has got a stressful event. Please remember that. Give proper education not only to the patient and relatives, also give proper education. Then only you can reduce the crisis. Ladies and gentlemen, I'm stopping here. Thank you very much for the kind attention. This is my team from Trivandrum Medical College. Thank you once again.
I would like to invite some questions from audience.
Thank you, Dr. Jabbar, for an excellent, informative talk, especially for the physicians and the endocrinologists also. I have a couple of comments and a couple of questions to make. What you have rightly said that probably prednisolone or dexamethasone, at least in the adult patient, is a more convenient form of replacement. But the younger generation, the trainees, guided by Western textbooks, they think that without hydrocortisone, you are doing an injustice to the patient. So that's a very pertinent point that you made. And what about the issues of iatrogenic Cushing syndrome that you get to see when the patients are on replacement? Is that really a problem? And what's your take on mineralocorticoid and sex steroid replacement in primary adrenal insufficiency?
Good question. I think you triggered for a controversial discussion now. But for heaven's sake, hydrocortisone is the best replacement molecule. There is no doubt about that. I think sir is going to make a comment. Sir, you are using lot of Visolon, right? Okay. And hydrocortisone tablets available, I think, for the last 10 years only. Before that, we were using, and you were using lot of Visolon. But dexamethasone is not a good choice for treating adrenal insufficiency. Is a one of the worst molecule for that matter, especially younger age group. Prednisolone, I'm very comfortable. We'll get the opinion of seniors also, sir.
I think you've brought out the points really nicely. Congratulations. I think the important point here is that it's a very imperfect replacement with hydrocortisone also. And there are so many patients, who are a little bit more sensitive or able to report more things, are quite unhappy when they get up in the morning. I mean, they're not good for the first few hours of the day, because whatever you might do, you don't get a good level at that time. And when do they have their hydrocortisone? So I think in patients, we use hydrocortisone as first choice in everybody, but by and large, if patients do report discomfort and they are not comfortable, there is fatigue in the morning, etc., then we don't have hesitation in trying hydrocortisone. In prednisolone, we don't really see too much of a problem with 5 milligram prednisolone. It's not a big deal, and so I wouldn't be watertight, like really straitjacketed about this. You can use prednisolone without much problem. Of course, dexamethasone is no question. So recognizing these issues, then that's why this chronocort and plenadrin and these timed release hydrocortisone preparations are becoming popular in Europe. One of them is given once a day, one is given twice a day to mimic the morning surge. The problem is that the biggest problem is in the morning. You need highest amount of cortisol in the morning, as you all very well know. But whatever you do right now, you don't get that. So you may give the hydrocortisone at 10 milligram or something at, or even 20 milligram at, but you'll give it at 7 a.m., 8 a.m. by the time the surge has already happened. So I think it is a very imperfect replacement what we are doing right now. And I think these technologies will at some point in the next few years become common practice and the main way to treat Addison's disease. It's not changed for I don't know how many years. It's the same this thing. So one quick query also, if maybe your questions you want to answer.
Regarding the DHEAs, okay, of course, see, when I was in Middle East, I used to give DHEAs. Okay, in Kerala, I don't have much experience, but personally, from my experience from Middle East, it's not really useful. Okay, and because of psychological belief that okay, this medicine is good, so that way they get you some mood elevation. Otherwise, practically what I feel, DHA is not useful. And yet other papers say that not only DHA, you should look into the medulla, adrenal medulla, epinephrine deficiency also you should address. People are thinking like that, but of course, only in the dream for the time being. Okay, and iatrogenic Cushing syndrome, such a common problem. See, I'm working in a multi-speciality medical college hospital. We have all the specialities. They are having lot of cases. Yet another point to add, even with a small dose of Visolon, we have seen cases of little Cushingod appearance also. Okay, it's only a couple of cases, but not that uncommon to see such type of phenomena also. Of course, forget about the 5 milligram, 7.5 milligram, and our patients are taking very high doses steroid for many other reasons also, and they will stop it. They'll go for crisis. That's also we have seen. So
The other thing, of course, that you all very well know is the dose requirement is also very variable and often times much lesser than what is the used to be the traditional dose requirement. And most patients do well with, say, if prednisolone maybe 5 and some even with 2.5, depending, of course, central and whether it's really Addison's or it's central. But I think this is important to realize that it has to be tailor-made according to the patient and the metabolic and the
yes.
clinical responses. We tried measuring cortisol levels in people on hydrocortisone. I'm not a great believer in that, but
Yes,
we
sir.
did try to see what is happening when patient is feeling so lousy in the morning till lunchtime. And the levels were actually quite low. And the best levels we were getting with the hydrocortisone replacement, because you can't measure with prednisolone, only with hydrocortisone, were in the afternoon actually.
Yes.
When the morning dose and the daytime dose have kicked in, and so those are important points, I think. I was asking a different question about adrenal insufficiency due to infective causes. Do you see a lot of histoplasmosis and others
So
in
our
your practice?
experience is, see, in my experience in Toronto Medical College, we have yet to see case of adrenal insufficiency due to infection, including tuberculosis or histoplasmosis. That's our experience.
Because one of the challenges that we face in histoplasma and other fungal adrenal infections is the antifungal therapy. How long does it go on? What are the criteria? I've searched and searched and discussed. I really haven't found satisfactory answers. Once established, when do you stop the because you don't know how much is reaching? Patient is okay, he's on steroid also. The lesion has regressed somewhat, but the changes don't go away on
Yes.
CT scan and everywhere. So it's one of those uh, sort of regular clinical problems that how do we handle these patients? Till when do we give them, antifungal, oral antifungal, and when do we stop? Just a question.
Thank you, sir.
So if there are
Sir,
no more questions, we can end the session now. Thank you,
sir,
sir,
one question, please. One.
for your kind deliberation.
So can I have the question, please?
Okay, okay. Oh, there is one more question.
Sir, in cases of AI, what are the situations where you will try to find out the etiology?
In all cases, you should look for the cause for adrenal insufficiency. And we used to go for antibodies. Of course, 21 hydroxy antibodies just only. Is it available here? I don't think so, sir. It's not available. And we used to go for imaging also. We did imaging for most of the patients. There is no doubt about that. And antibody profile, surrogate marker as antibody, thyroid antibody you can ask for. And sometimes you'll ask for other, mostly we'll go for see histoplasma antigen, all those things we used to do, but we did not get any positive answer for that. Ideally, for all patients with adrenal insufficiency, have you made a diagnosis of Addison, you should try to, or you should search for a etiology. There is no doubt. Thank you.
Thank you, sir. So before the start of our next session, we'll have a 10 minutes tea break for a little bit of our arrangement. So we'll meet here again at sharp 11:55. তাহলে তুই just sharp outers ব্যাস তাহলে so we'll have to start the session now. So we have Dr. Shoroshi Ranjan Mukherjee Memorial Oration for the next session. So for this next session, we have two chairpersons, Dr. Dasharati Sarkar and Dr. Moutushi Roychaudhary. I would like to request them to have their chairs, please. Mike.
And so we come to the prestigious oration of Endocrine Society of Bengal, the Dr. Shoroshi Ranjan Mukherjee Memorial Oration. And Dr. Shoroshi Ranjan Mukherjee's area of specialization was nuclear medicine with a special interest in endocrinology. And he did a lot of innovative work and pioneering research in a number of fields. So with that, today the oration will be delivered by none other than Dr. Amrish Mittal. So it's my pleasure to invite him to the podium.
Dr. Ambrish Mittal, Chairman and Head of the Endocrinology. Previous slide, please. Previous slide, please.
I would like to invite our chairpersons to hand over the medal to Dr. Amrish Mittal first.
And now we will be handing over the citation, certificate of oration. The certificate is presented to Dr. Amrish Mittal for delivering an oration on building better bones, advances in osteoporosis management during Crescendo 2024 annual conference of Endocrine Society of Bengal, held on 21st to 22nd September 2024 at Donodanno Auditorium, Kolkata.
Thanks.
Thank you very much, the organizers, for inviting me, the chairpersons for introducing me. It's a big honor to be in the city of joy with an invitation to deliver an oration named after such an illustrious personality. Uh, in fact, this has been pending for the last 1 or 2 years. Something has been going wrong. I'm happy I could make it this time. So, I'll be talking a little bit about osteoporosis management and advances. I will not be dwelling on the normal algorithm for treatment and what we should do, that all of you are aware, because this is primarily an endocrine audience. But we will be talking a little about what is changing, what has changed, a little bit about that, and where do we see this going in the future, especially in the Indian context. Largely, I'll be focusing on management, that is treatment. So that, for those of you who may not have visited our hospital, I work at the Max Hospital in Delhi, the Saket, which is the central or the flagship hospital. And this is a view from my OPD chamber at the time of sunset. And you can see the Qutub Minar in the background and the yellow glowing ball that is slowly descending to say goodbye for the day. Uh, I'll divide the talk into several small sections to make it easier. So the one would be, of course, a little bit about the background and treatment indications, then something about bisphosphonates, denosumab, teriparatide, abaloparatide, romosozumab, the most exciting new development, and the use of bone turnover markers, which I do consider relatively new in the Indian context, and which is something we have been using very successfully for past few years. So again, we don't, as I said, go into all the guidelines and all for this, but we know that postmenopausal women over 50 presenting with an osteoporotic fracture, which classically means a hip fracture or vertebral fragility fracture, found clinically or on imaging. And I think that's very important. One of the most neglected tests in osteoporosis management is a lateral spine X-ray. Not everyone can have a VFA available and all those fancy new things, but a lateral spine X-ray properly done picks up, especially in the elderly, many minor or major asymptomatic vertebral fractures, which will then decide for you the treatment. It's like, we keep chasing the bone density. Sometimes it's like, measuring the cholesterol in someone who has had a myocardial infarction. So yes, it is important to measure it, but if someone has had an event, then the whole story changes, and then you will treat the patient accordingly as a high risk patient. So this is important. And in general, hip and spine, yes, but shoulder fracture is also now considered an osteoporotic fracture. So all the newer papers and newer guidelines will include shoulder also. So people who fall, trip and fall and break their shoulder should be treated like osteoporosis, like fragility fractures. Of course, the trauma has to be minimal. If it's a football trauma, it's a different story altogether. The other important concept in this is that a recent fracture, if you've had a fracture within last 2 years, you are at great risk of a subsequent fracture. And therefore, there's a slight sense of urgency in instituting treatment after a fracture, because such people tend to fracture again very soon. And I think that's something that is sometimes missing. What happens often, as I see in practices, people get treatment for a few weeks by the orthopedic surgeon, and then they're lost to follow up and come back 5 years later with another fracture. So I think it's important that we focus significantly on treating those who've had a recent fracture. So in my book, the best way to do that would be everyone who gets a hip fracture before discharge gets an infusion of zoledronic acid. as an example, as a standard protocol. What that will do is it will clearly reduce the risk of hip fracture. With zoledronic acid, there is no risk of rebound. So you're not worried the patient disappears. The effect will only slowly wane off. It goes beyond 1 year, as we know that very well. So those are important areas. There is data from Ian Reed's group which suggests that a single infusion can protect up to 18 months quite easily, maybe more. So we are not worried, unlike with denosumab, where you're worried about the 6-month cutoff and the immediate. So the rebound increase in fractures. So I think, as I'm just suggesting, as a practical sort of thing, we are still unable to convince the orthopedic surgeons to do it routinely. And one of the reasons this is genuine is that if someone does develop a flu-like reaction post-operatively, they are quite concerned about that, what to do, and it can lead them to suspect infection or something, and that's why it's confusing for the patient. But I think that is the future, one of the practical public health policies that we can implement. Anyone coming with hip fracture before discharge gets a zoledronic acid infusion. Of course, the bone density criteria are very important. The role of FRAX, we know that there is a FRAX India on the website, but the fact is that that's based on Singapore Indians, so always keep that in mind. And whatever experience we've had and studies we've done suggest that is under predicts fractures. So there is a sense, it doesn't really predict it accurately, and many people would not be qualifying for treatment based on their FRAX score, whereas actually they are at higher risk. So it underestimates. Still, it gives you a good idea. And now we have FRAX Plus and others which incorporate other risk factors, including diabetes, so which is making it more and more accurate. But unfortunately, the data from India, which is accurate hip fracture rates, is almost impossible to obtain. So that is proving to be the biggest challenge in more accurate epidemiology of this condition in India. So yes, this of course, I would suggest you use the FRAX frequently. This 20% and 3% cutoff, 3% cutoff on FRAX as a predictor of major hip fracture and 20%. So I think these are a little sort of off. They are not necessarily applicable. Maybe 3% is applicable everywhere, but for the MOF, maybe you should look at much lower figures of 10%, 12%. Lakshmi Nagendra is doing some studies, maybe 14%, something in that zone. Don't have to wait for 20% cutoff to decide about the risk and your treatment. So just a few tips about what is happening with the FRAX story. Imminent fracture, as I already said, is exceedingly important. And within those who've had a fracture, who are the people who have greater risk? There are several studies on this, and I found this sort of pretty reasonable. In elderly women, predictors of fracture within 1 year. Prior fracture is obviously what I was talking about. If you've had a fracture, first 2 years, first year especially, you're at great risk of a subsequent fracture. A low bone density along with a fracture, impaired physical function. Impaired physical functioning is much neglected. Much of the fracture risk is not related to bone density alone, but is related to risk of falling, sarcopenia, lack of balance, visual effects, postural hypotension at night in elderly patients who go up to get up to pass urine or something, and they have a little tumble. Those are very, very common things. Fall prevention strategies, I mean, really important. Definitely poorer general health. As you were discussing with somebody over breakfast, people who are frail and petite, that they are likely to fall. You see that all the time in your clinical practice, and that itself can be a predictor of fracture. If you look at old studies, BMI was almost as good as predicting fractures as BMD. So there are studies to show that. What I'm saying is that frailty is neglected. And we are seeing much more of that because Indians are living longer. Again, not a day now honestly goes by when I don't see a nonagenarian, someone who's 90 or 92 and, comes to the OPD either in a wheelchair, with a walker, or sometimes just walking. And they are the ones who are prone to all these. They've survived their cardiac episodes. All that thing is done. So now what is the biggest fear for them is falling and breaking a bone. So I think we need to be careful about this, need to modify our practice accordingly, modify our situation. I have a big challenge in treating geriatric elderly patients because I see a lot of osteoporosis. It's incredibly difficult in a crowded OPD with dozens of type 2 diabetics waiting, and to give them the kind of attention they require. Even taking off their shoes to see their feet is a big challenge, and we are seeing more and more of those patients. So what I'm saying is we need to focus, we'll have to focus, all of us, on the elderly and geriatric patients, and not just prescribe them medication. Like when you prescribe medication for diabetes, you're only doing half your job, or not even half actually. The same in osteoporosis, unless we are talking to them about muscle strength and fracture risk, fall risk reduction, our job is not really done. And bone density can be misleading, and we're finding that more and more, especially in the very elderly. Like this kind of patient, if you can, this is not a great picture, it's got cut off, but you see the calcified ribs here, and you see the aortic calcification here, and you see this. Now, this 91-year-old lady, I've been seeing her since she was 75 or something. Uh, you wouldn't find anything in the bone density. If you did a bone density of the spine, it'll be okay. It won't pick it up because there's aortic calcification, there is, vertebrae are compressed, and there is so much osteoarthritic changes. So remember that, especially in the elderly, which means especially in those over 65 or 70, you can use a cutoff. But best to do a lateral spine X-ray when you order a bone density. It doesn't cost that much, and you will miss some, but you will pick up some. So at least you will add to the pool of patients who require treatment. I think this is very so. In our practice now, it is routine to ask for a lateral spine X-ray when we are asking for a bone density. Another example: this is another patient who's been under follow-up for many years. This is how she came in 2012, by the way, and she's maintained like that. No further fractures, because she has been regular with whatever treatment was advised and following all advice. So it's unbelievable that this woman is now 80 plus and she's all right. I mean, she's not worsening. We didn't find any secondary cause or anything. It is straightforward osteoporosis. Look at those vertebrae all over. So this is to give you a perspective. And then what really are the drug therapies? We know, again, I'm not going to classifying, you know that very well, anti-resorptive agents or anti-remodeling, bisphosphonates and denosumab are the ones worth talking about. In anabolic agents, teriparatide and romosozumab, which may actually be both anti-resorptive and anabolic, but primarily perhaps anabolic. These are the four molecules we'll really be talking about. What about bisphosphonates? We're not going to talk about their mechanism of action. You know that very well. You know their efficacy. You've been using them for decades. Just remember, 3 years zoledronic acid, reassess, and then you can go up to 6 years if required. Oral bisphosphonates, alendronate is the only one we're using commonly. Go up to, again, 5 years, reassess, and then you can go on for another few years if required. So that you'll have to take a clinical call based on the risk at the end of 3 years with IV and 5 years with oral bisphosphonate. What exactly is required to be done? You want to continue, not continue. There's significant improvement. You can discontinue. Poor response, you want to switch to something else, to an anabolic agent, right? And if at the end of 3 to 5 years, the risk is definitely reduced and nothing much, then you can take so-called drug holiday, which is a hotly contested term, but you can go off the bisphosphonate, follow up with bone turnover markers, bone densities every year or every 2 years, and then decide when you want to reintroduce therapy. So this drug holiday concept is only for bisphosphonates and not for anything else. And that's because their effect lasts long, they stay in the bone, and sometimes you can see the effects persisting for much longer than what is the sort of expected duration of effect. So it is possible if someone is lower risk now than when you started out, then you can consider going off these. And at 3 years for intravenous and 5 years for oral, you should reassess your patient. Now, nothing else you're fully aware of. I'm not going to ONJ at atypical femoral fracture. You know all that. But one of the challenges we have with zoledronic acid is the fact that the acute phase reaction. the flu-like reaction, which can be a big turn-off for some patients. Some patients rarely even get hit with oral bisphosphonate, by the way. But definitely with zoledronic acid, 10 to 15% people, some studies show even 20% get this flu-like reaction. What we are doing at the moment, we are giving NSAIDs to everybody for 3 days without discussing anything. It's like a protocol. You take these for 3 days. Some of them do fine with that. A few of them don't, and then we have to, continue them for longer. Many of them have no effect at all, no side effects at all of the infusion. So Ian Reid's group did something adventurous. I thought they did a randomized control trial where they gave 4 milligram dexamethasone, which I thought was a pretty solid dose for 3 days, and versus placebo, and they found a dramatic lowering of or virtually eliminating the acute phase reaction. So that is a protocol in someone who is very anxious, where you are very concerned. I don't think this can be a standard protocol yet. Maybe we can try a lower dose of dexamethasone. Many of our patients have diabetes also, and you give 3 days dexamethasone. If they measure their sugars, and sugars go to 400, another problem you're causing for yourself as well as for the patient. So, but this is a proven option in patients where either you are concerned or patient is very anxious. You can give them 2 to 3 days of dexamethasone along with the infusion so that you can reduce the risk. But I do suggest, unless there is a kidney issue, you please give them NSAIDs for 3 days anyway. This just to avoid your own headache. They may not require it, but 2 or 3 days is not going to hurt anybody, and most of them will feel fine with that. Now, not too much about this. Denosumab is very exciting. We've all been using it now for a few years. We all know it's a rank ligand inhibitor, very different from bisphosphonate, which is a osteoclast poison. Both are anti-resorptives. Bisphosphonates coat the bone, osteoclast comes there, chews up the bone and dies. So the bone surface is full of dead osteoclasts in the case of bisphosphonates. In in the case of denosumab, it's a completely different action. It's a rank ligand which is inhibited. So therefore, the crosstalk between osteoblast and osteoclast, the stimuli that promote osteoclastogenesis are inhibited by the rank ligand. So quite clearly, then there is less formation of osteoclasts. So it is said that in a bisphosphonate treated bone, if you see the bone surface, it is like a battlefield where everyone has died. Osteoclasts are dead and dying all over. In denosumab, you don't allow the enemy to reach the battlefield. So there are much fewer osteoclasts. So that's why it is. So there is a completely different mode of action. But the important part, of course, with denosumab is that it has a finite duration of action, and there is a quick escape. This is a good point and a bad point. If you're looking at over suppressing, that is less likely. You can stop the medicine. If you're looking at safety, if the patient is delayed or does not take the injection, it's a big challenge. The other challenge, of course, is with zoledronic acid. It has to be given in hospital. This is easy to administer, and subcutaneous, nothing like no issues, and very few acute phase reactions. Very few. But so that safety is there with denosumab. So if the patient can take it 6 monthly, what happens? We know the good thing about denosumab is that the bone density continues to rise for 10 years, maybe more, but 10 years data is there. It just continues to rise. So that is, it's not that it reaches a good level and is plateaued. It continues to rise for 10 years. So there's obviously no drug holiday, but it's a very powerful drug, anti-resorptive, and works. At 5 years, again, you will reassess where you are and then take a call whether you want to continue or change or whatever. But you can go up to 10 years. But this is the challenge. What happens when you discontinue? There are vertebral fractures after discontinuation, which are serious, can definitely increase. So, the moment you stop, you may increase the vertebral fractures over the next few months. That's a challenge. And the other important part here is that what to do for this now. And what is done for this is now, and I'll explain that zoledronic acid infusion has to be given at this point. So when you're stopping denosumab, make sure you give a zoledronic acid infusion. But anyway, this is one part of denosumab. The other part is that it's almost treat to target, like we talk in diabetes. Only with denosumab, you can bring the T scores to a particular level. So if the T scores are going below -2, 1.5 to 2, then you can think of discontinuing the treatment. So you can, in the case of denosumab, the correlation between T-score and fracture is very strong, and it can be used as a criterion for response. So can some people really believe in this? But it's still incubating. Can a specific T-score be a target of treatment, like an HbA1c? Can you use it like that? So amongst all the confusion about denosumab, about how to withdraw, and no one really has enough data. There is a few studies. So the ECTS came out with some guidelines. This is important for all of us. Individuals with high fracture risk for more than 2.5 years should continue denosumab for up to 10 years. As I said, you can go up to 10 years. Or switch to zoledronic acid starting 6 months after last denosumab. So whenever denosumab is due, then you give zoledronic acid and monitor bone turnover markers. A repeat dose should be considered. So it's not that you give annual zoledronic acid. If you discontinue denosumab, you give zoledronic acid, and then again measure at 3 to 6 months, you may have to give another one. So that is important. Or you can use oral alendronate. But everything is veering towards zoledronate following denosumab, and most people require 2 or 3 infusions. 2 almost all require. We have a lot of patients now where we are discontinuing. So you still have to go back to good old bisphosphonate, and you need at least 2 infusions, 1, 0, and 6 months, like that. And here, bone turnover markers targets are very important. We are using, and I'm sure many of you are, bone turnover markers liberally in our practice now. And CTX is not that difficult. We are not finding that much problem in the assay or anything. And if you use some targets, one rough cutoff is 280 for CTX and less than 35. PA1NP is not so important in this case, but less than 280 for CTX, then you're okay. Then you don't have to give the next zoledronic acid. That's where you stop. So this is very, very important clinical point. What about teriparatide? We know it works for vertebral fractures. I'm not going to waste your time. Everyone knows, everyone uses teriparatide. You know that the duration of treatment is typically 2 years, right? And also it works best when it's given to a drug-naive patient, like right in the beginning, although it works after antiresorptives also, but the best action is when it's given like to someone who has not received anything. Anyway, the data on teriparatide, even to date, in terms of RCT data, is only about spinal fractures. Hip fracture data with teriparatide is still, there is no RCT, and no one's going to do it now. So the major thing is that you can use it for longer. The FDA now says you can use it for up to 3 years. They don't specify, but they say you can go for longer in these very high risk patients, especially those on glucocorticoids if you're using it. High fracture risk with P1P level that remains high, high fracture risk, multiple compression fractures, adynamic renal bone disease, severe chronic obstructive pulmonary disease. So FDA just said high risk patients. Paul Miller tried to list which are the patients where you can continue teriparatide for longer, either in one go or you can come back to it later after a few years of bisphosphonates. Not that 2 years in a lifetime is mandatory. You can go a little above that. No one knows the exact cutoff, whether it's 3 years or 4 years, but you can go. So I have definitely gone up to 3 years in 2 different installments. And then what do you do after teriparatide? Again, you need to do something, right? Because when you give an anabolic therapy, you need to give something after that. And yes, it's important then to decide what to do. We've traditionally been giving bisphosphonates, right, after teriparatide, but it's very, very clear that denosumab is superior to bisphosphonate. So in this case, when you're switching from teriparatide, now that denosumab is freely available, definitely switch to denosumab rather than zoledronic acid, unless there's a reason. You may have specific reasons of compliance or whatever, but otherwise, preferred option, because not only does it keep the spinal BMD, it actually, when you look at hip strength by finite element analysis, denosumab improves the hip strength beyond what teriparatide did. As I said, teriparatide hip data is always a little, suspect. So if you're using teriparatide followed by denosumab, you get the best results for your patient in terms of both spine and hip fracture prevention. So in practical terms, that is a very, very good, powerful regime to follow. Then, of course, the Japanese keep working on once weekly teriparatide and some very interesting data, but I won't go into details, but this is a possibility. The West hasn't accepted that. Sometimes there is a difference between what West does and Japan does. But clearly, the studies on weekly teriparatide are very impressive. So it may be a very viable option in the future, once a week teriparatide. Sorry. So we tried to look at the efficacy through a meta-analysis that because other than denosumab, we weren't finding that the T score is so accurate a reflection of the response to drugs. And I'm not taking you to the study just published, in fact, last month, which looked at a meta-analysis actually and found a significant impact on bone material and bone quality with anti-osteoporotic agents, right? So I think this is important that it's not just bone density, which people who sell denosumab will have you believe. It's also a lot of impact on bone structure and quality that determines anti-fracture efficacy of these agents. This was a recent meta-analysis that I was part of. What about abaloparatide? We've understood new things about zoledronic acid, new things about teriparatide. What about abaloparatide? So abaloparatide is a PTH-RP analog. I mean, in all honesty, I read almost all the papers on abaloparatide. It's okay, but I don't see it becoming like a huge thing or any significant superiority over teriparatide. There are studies here and there, but no clear this thing. So there is difference in bone density. It seems with abaloparatide there is a slightly greater increase in bone density as compared to teriparatide, right? So maybe let's see, especially at hip. Again, we are going back to the hip. Teriparatide and hip don't have a great relationship, although all the models tell you that they will reduce fracture risk at hip also, but direct studies have not been done. So here also, at the bone, in the bone density part, abaloparatide seems to score over teriparatide in a little bit in the bone density part. And in this, these are kind of studies that always, I'm not very fond of. Administrative claims database study, and then they showed that maybe the hip fracture probability was a little lower with abaloparatide. I mean, it's okay. You can take a hint from there, but I don't say that abaloparatide is a huge advance and is going to replace teriparatide. I don't think so, especially with the cost concerns. And in our country, teriparatide is very inexpensive, so no problem. Last part, or second last part, is romosozumab. There's a new kid on the block and very exciting. Have people started using romosozumab here in the audience? Are people using? So you'll start sooner or later because it's an amazing molecule. We've just started. We've got the first few patients on romosozumab. It's a very interesting concept related to LRP5. And this, again, all advances in medicine happen from the study of rare disease. So this LRP5 mutation, where sclerostin was not being formed, leads to several skeletal abnormalities, including dense bones. So, osteosclerosis. And these cases have been described, and people keep doing, case series, and everyone has one case, half a case, two cases like that. Now, when you have when you're able to form less sclerostin, which means if you're able to inhibit sclerostin, then the bone density goes up. And that is the concept. The concept here was that romosozumab exerts a dual effect. And why is that? Because it inhibits sclerostin. Sclerostin is made, where is it made? In the osteocyte. Till 15 years ago, we thought osteocyte is a useless cell. We don't know what to do with it. No one knows what it does. But these are embedded in the bone, and they seem like innocuous, but they are the triggers that start bone remodeling, that initiate bone remodeling. So sclerostin is a very important concept there. If you inhibit sclerostin, then you're not only acting on osteoblast, but also on osteoclast. And that is why romosozumab is a dual action agent, anabolic as well as anti-resorptive. That's the action of romosozumab, sclerostin inhibitor. And again, non-vertebral fractures, look at hip fracture reduction, 38%, which is pretty impressive. It's 20-25% with most agents. So there is a significant reduction in risk of hip fracture as compared to placebo, as compared to alendronate in this study. So this is the difference with alendronate. And they did a head-to-head, which is unusual, but they did a head-to-head, and they found clearly romosozumab is superior to alendronate in reducing the risk of fracture. Look at the bone density differences. The red line is alendronate. The blue line is romosozumab, right? There you go. No question about it, right? So it's very powerful. It's given once a month, at, and it's 210 milligram once a month. One shot is 105 milligrams, so both are taken together. So 210 milligram once a month for 1 year, for 1 year only at the moment, 1 year only. But like with all good things, there's a challenge. The challenge was the study on adverse events when compared to alendronate group. There was a greater risk of cardiac ischemic events and cerebrovascular events. It wasn't a huge increase. The absolute numbers were small. And this is an elderly population, but it was there. So never ignore a signal, it is there. So even though, and I'm not showing those studies, the frame study, the largest study, which used romosozumab versus placebo, there was no difference. But in the study versus alendronate, there seemed to be a greater risk. So that put a bit of a spanner there. So it's not recommended for those who have had coronary or cerebrovascular events in the last 1 year. Those who have had recent events, you can ignore it there. Although why 1 year, why this, it's all very questionable. But this is how it is. And unfortunately, most of our patients have cardiac issues at that age, or many of them do. So you have to be cautious about that. Now, when you compare romosozumab versus teriparatide, again using for measures of bone strength, using finite element analysis, you find that for hip, the blue line is romosozumab, the red line is teriparatide. For hip, romosozumab clearly was superior in improving hip strength as compared to teriparatide. So, while for spine, they were more or less equivalent, but for hip, romosozumab was clearly superior, making it probably the agent of choice for severe osteoporosis. So many guidelines are now including romosozumab right at the beginning. Just this is the Royal Society guideline from UK. Now they're saying severe osteoporosis minus 2.5, multiple fractures, hip and spine. It can be used right at the beginning. So this, you all know the principles of management. Again, I'm not going to go into this. The important part here is that you don't need to maintain very high levels of D. By and large, anything above 20 nanograms is okay. Please do not, the labs are not changing despite my multiple requests. They mentioned normal range of 30 to 100 nanograms in Delhi, and the patient is panicking at 28 nanograms. So that's a big challenge for us. But anything above 20 nanogram or 50 nanomoles is good. Thus, yes, maybe you're treating for osteoporosis, you go up to 30, 35, but no need to think of 50, 60 and giving all those useless injectables and high doses of this thing. And also, daily doses. This is something that I'm part of, the global vitamin D group. And, this is all you have to remember. By and large, if you're maintaining above 20, your patient is quite safe. 20 nanograms or 50 nanomoles. Now, I'm not covering combination therapies today, but only in where risk is very, very high, you can consider combination of, say, teriparatide plus denosumab or teriparatide plus bisphosphonate, but typically teriparatide plus denosumab. We won't go into that too much. What about use of bone turnover markers? The last part of the talk. We should try to get our numbers in order when we are treating with anti-resorptives. It's different with the anabolic agents. So it's important that we try to achieve CTX of less than 100 or decrease of at least 100 and below 280, as I already mentioned. But this is important. This is almost for us now in the clinic like an HbA1c for follow-up. The patients come every 6 months, they come with their bone turnover markers. But what are the drawbacks we are seeing in just last couple of minutes? I know time is about to be up. Just 2-3 cases, just to illustrate how bone turnover markers are. This is a 52-year-old lady. Can you believe it? Menopause in early 40s, osteoporosis diagnosed. She is very, very fit. Look at her weight, 46 kilograms. She's a karate black belt, by the way. Okay, so very strong. Now, but she did a bone density, and now she wants to know whether she can resume her karate or not. Now, that's a big challenge for me to say yes or no, because what happens here is that her bone density was really low, And when we gave her denosumab, because she wasn't willing for zoledronic acid or anything, that's another factor in everything, patient agreement. And then it's nicely flat. So what I'm telling you, this is a classic good responder to denosumab, right? But see the next patient. This is a lady, 65-year-old, compression fracture already, 2018. That's when she was diagnosed. And this is what happens to her bone turnover marker with denosumab. At 3 months, they are rock bottom. By 5.5 months, 6 months, they are back to almost where they were, 800, 900, 1000. So she does not retain the suppression of CTX for full 6 months. Now, this is a challenge. We don't know whether such patients should be given denosumab more frequently. There is no data. Intuitively, you think yes, but there is no real data. It's something that we are thinking of looking at, because roughly 20-30% of our patients are like that, and only a few are this beautiful. Where at 6 months, so when patient comes at 6 months with a very minor decline in CTX, then we always get after the next injection, get it done at 3 months. And this is the kind of thing that we find, as I showed you. Look at the difference here. The Prolia action just disappears, it looks like. So this, I suspect, will be a challenge, and Prolia is not discussed so much, because all your trials show that flat thing all the time. It's not like that. We have many patients like this, and they're not using generic, they're using original denosumab, same stuff that people abroad are using. And the last case is a 91-year-old lady. I mean, we are seeing a lot of geriatric patients, and she's been on my treatment. Just to illustrate sequential therapy, she started her zoledronic acid, moved to teriparatide for a couple of years. In between, there was a bit of a problem with the pandemic with everybody. For 1 or 2 years, treatment was a bit haywire. And then July 22 onward, she's on Prolia. She clearly had, this is the lady whose X-ray I had shown earlier. Yeah, same. So look at that. Look at her spine. She has significant fractures. She uses a walker, sometimes a wheelchair, but she's fairly independent, and she's 91, and not one additional fracture after 2012. So that I consider the success of proper osteoporosis management, and she gets good care, good supportive care also. She's a doctor herself. So I think these are illustrative cases just to show you. In her case, again, so it at least remains at a reasonable level, no? This is after zoledronic acid. It was already below 280. And then when we are giving Prolia, denosumab, then it remains okay. But there are enough patients like the previous one where I showed all this swinging. You're supposed to look for causes, why it is happening. We've checked out all the causes. There's nothing else. There's not PHPT, not anything else that we have missed, that is causing that fluctuation. Thank you very much. And this is the group we have a large endocrine group in Max across the South Delhi facilities. We have adult endocrinologists, we have pediatric endocrinologists, we have some people who do only diabetes. We have a DNB program with students, and it's a large group managing endocrinology in Max. And this I put here because it's a talk of osteoporosis, and this is the oldest surviving structure in Delhi. This is probably built around 800 to 980, Anang Tomar, maybe even before Prithviraj Chauhan. And so this is ruins of that, and you can walk up right up till there. It's interesting because the history of Delhi is quite fascinating, as I'm sure is the history of Calcutta. Thank you very much.
Thanks, Professor Mittal, for your lucid and illuminative deliberation. And Professor Mittal is the legend person in the sphere of the bone health. I think you have much more questions, but this oration session, questions is not possible here. You can contact Professor Mittal in the lunch time.
Sure.
Okay,
Thank you very much. Thank you.
And it was a great pleasure. That brilliant oration from the doyen in the field of bone health. So
Thank you, ma'am.
Thank you so much. And as Dr. Sarkar said, we will not have any questions because it's an oration. So with this, we end the session and hand over the podium to the organizers. Thank you.
Thank you, sir. Now we are moving on to our next sessions on obesity. So for that, The first session is on metabolically healthy obesity, facts and fantasy. I would like to call upon stage Professor Dr. Shombit Dash, who is Professor and Head of the Department of KIMS Medical College and Super Specialty Hospital, Bhubaneswar.
So, a very good afternoon, one and all. And at the outset, I must thank Team Crescendo for giving this opportunity. So, I'll be speaking on a topic which is very important, that is metabolically healthy obesity, fact and fantasy. So, what do we mean by metabolically healthy obesity? So, the agenda of my discussion is there are 3 points which I'll be discussing. First is what is metabolically healthy obesity, second is what is its significance, third is when and how should we intervene. So these are the three things which I'll be discussing in the next 15 to 20 minutes. So coming to what is metabolically healthy obesity. So this is the problem statement, and obesity has gone into a mammoth proportion, and you can see two-thirds of the world has been painted now with red or maybe dark red. So that shows the prevalence of obesity has gone from 60 or 70%. In India also, the data is not that good because this is the secondary data analysis of the National Family Health Survey by Dr. Nitin Kapoor et al., who have shown that the prevalence of obesity and overweight in men is around 38.4%, and for women it is around 36.2%. So it's that huge a problem. So this is the ESI clinical practice guideline for the evaluation and management of obesity. And here also, and in the other studies also, the obesity was diagnosed and the cutoff was laid down by body mass index, and the BMI was the cutoff. And you can see the Asian cutoff of more than 25 kg per meter square as obesity. And but there is a clear cut mention that the obesity should not be diagnosed or managed with only BMI alone, and assessment of obesity should be done beyond the numbers. Because if you are doing assessment of obesity and defining obesity with BMI alone, then though it's convenient, it is not the best way to assess obesity in the Indian setting, because there are so many other factors that also play into role. So we need to take a comprehensive method of diagnosing and managing obesity. So why we should not take BMI as the sole cutoff? Because if you see the BMI cutoff, we have the normal body mass index, we have the overweight or obese individuals, and then we have the morbid obesity. But you can see that a chunk of the patient in the normal body mass index have actually some metabolic abnormality, and we call it as normal weight obesity. And they have higher chances of complications, higher chances of metabolic complication, and even cardiovascular mortality. At the same time, if we diagnose according to the BMI as obese individuals, there is still a section of the population who have who don't have the metabolic complication or the other metabolic abnormality, and we call it as metabolically healthy obesity. And today we'll be discussing on this chunk of patients who are, though obese as per the BMI cutoff, are not having any of the metabolic abnormality. So that's known as the MHO, or metabolically healthy obesity. Now, the concept of MHO is not recent, and it has come way back in 1940s, where it has been they've mentioned by Vogue et al. That it is the adipose topography which is important, where the adipocyte is deposited, that is more important rather than the waist circumference or the BMI. And that is in 1940. But in 1980s, Ruderman et al. Have introduced the term as metabolically obese normal weight. So they have coined the term as normal weight metabolic obesity. And in 1990, Sims et al. Have told there is a component in the obese individuals where they do not have any metabolic abnormality, that's known as the metabolic healthy obesity. So the concept is not new, but the uh, mm, but the recent advances are quite huge. So De Lorenzo et al. Have actually divided, according to the adiposopathy, five category of individual in that spectrum. So one is the normal weight individual, but they are normal weight and lean. Then there is another group of individual that is normal weight, centrally obese. Then the third category is metabolically obese normal individual. And in the obese category, when the BMI is more than 30 kg per meter square, they've divided the two groups. One is metabolically healthy obese, and another is metabolically unhealthy obese. And MHO is the discussion point for today's talk. So this is the obese phenotype, the four important phenotypes where MHO is the metabolically healthy obese. Among the obese individuals, there is a chunk where there is no metabolic abnormality, and that is known as the metabolically healthy obesity. So the definition also varies, and there are many definitions that has been proposed, but the most widely used definition is this one. So the following criteria have been proposed, that is the in addition to obesity, that is BMI is more than 30 kg per meter square, but the fasting triglyceride level is less than 150. HDL cholesterol is more than 40 in men and more than 50 in women. Systolic blood pressure is less than 130 millimeter of mercury and diastolic less than 85 millimeter of mercury, and the fasting plasma glucose is less than equal to 100 milligrams. So a person who is obese, who doesn't have this metabolic syndrome criteria are been included. Plus, they've used the other criteria, that is no drug treatment for dyslipidemia, diabetes, or hypertension. The person should not be on any of these drugs, and there should not be any cardiovascular disease manifestation. So this is the most commonly used definition for metabolically healthy obesity. Though the definition, as I told, it's in a dynamic process, and the recent definition from the Nature Reviews in 2024, they have used a novel MHO definition where they have taken as there should not be no prevalent diabetes in the person who is obese, and no blood pressure lowering medication the person should not be having. Systolic blood pressure is less than 130 milligram per deciliter, and they have taken waist to hip ratio in their criteria. They have taken waist to hip of less than 0.95 for women and less than 1.03 per ml for classifying the metabolically healthy obesity. And they've used that in the enhanced 3 participants, and they have also validated with an external cohort like the UK block participants, and they have told probably this definition is more appropriate for metabolically healthy obesity. These are the different definition as per the different criteria used. Some have used even the HOMA-IR or the insulin resistance criteria, and so also the prevalence varies, because the way you use the metabolically healthy obesity definition, so also the prevalence varies. Because if we take the conventional definition, then 40% of the participants in the enhanced 3 were categorized into MHO, but only 20% fell into metabolically healthy obesity category using more stricter insulin sensitivity criteria of HOMA-IR and all. So the prevalence of MHO is not very strict because the definition has not been very clear cut. But if you take the most prevalent definition or the most widely used definition, then in obesity class 1, you have around 28% of patients who are metabolically healthy obese, and in obesity class 2 and 3, you have around 15% who are metabolically healthy obese. So this is one of the graph. As you can see, the red one are metabolically unhealthy and the blue one are metabolically healthy. And as the BMI increases to class 1 and class 2 and 3, so also the metabolically healthy obesity prevalence goes down. So it's around 29% for class 1 obesity and around 16% for class 2 and class 3 obesity. But one thing is very clear: if you compare metabolically healthy obese versus metabolically unhealthy obese of the same BMI, there are certain subtle differences, and there the total body fat is more for metabolically unhealthy obesity. And if you see the truncal adipose tissue, that is the visceral fat content, is definitely higher with metabolically unhealthy obesity compared to metabolically healthy obesity. So the visceral adipose tissue is actually lower in metabolically healthy obesity even with the same BMI. So that's about the metabolically healthy obesity, the definition, the prevalence, and all. So, what is the significance? So, are we adding anything to our clinical practice by knowing MHO? So, to know the significance, we have to see three things. One is whether it is pathophysiologically a distinct entity or not, or it is just a spectrum of that. Second, what are the cardiometabolic risk factors associated with metabolic healthy obesity? And third is the risk of progression, whether they progress to metabolically unhealthy obesity or they remain static at that point. Coming to the first point, that is whether there is pathophysiologically distinct entity or not, there are many articles, there are many review articles. The recent one is this Nature review in 2024 August, and what they have told is that yes, there is a distinct entity to that, because pathophysiologically it has been demonstrated in animal models and mouse models that such an entity exists in obesity, and the cause for that increased metabolically healthy obesity is because of increased adipogenesis in the subcutaneous adipose tissue, increased de novo lipogenesis in adipocytes from subcutaneous adipose tissue, and there are some decreased mitochondrial iron transport mechanism into the mitochondrial matrix, and there is increased adiponectin and decreased inflammatory pathway signaling. So these were the probably the MHO obesity phenotype in the animal model. And if you see the animal into the human model also, the MRI pattern, you can see there is in metabolically healthy obesity on the left side versus metabolically fat on the right side. The subcutaneous fat is more in metabolically healthy obese people, the liver fat is less, and there is a substantially less visceral fat deposition in the metabolically healthy obese compared to the metabolically unhealthy obesity. So what has been proposed is that, so with high energy intake is the first trigger factor, and sedentary lifestyle. But what is more important is the genetic and some of the hormonal changes. Though they have not found out any single specific gene, but they have proposed probably the adiponectin receptor, adiponectin gene is probably responsible for this metabolic healthy obesity. Because for metabolically healthy obesity, the predominant factor is lipids are deposited mostly in the gluteofemoral white adipose tissue deposition, whereas for metabolically unhealthy obesity, it is mostly the large visceral white adipose tissue deposition, even at the same BMI. So that probably is regulated by some genetic factors, and probably the future research will be able to tell that. And the second factor is whether metabolically healthy obesity has got some cardiovascular advantages compared to the unhealthy obesity. The answer is yes, because in this study of mean follow-up of 5.4 years in obese individuals with no metabolic parameters, they found a higher risk of hazard ratio for cerebrovascular disease, for heart failure, and for the coronary heart disease, in compared to the normal weight metabolically normal individuals, but it is significantly lower compared to the metabolically unhealthy obesity. So if you see the meta-analysis here, the metabolically healthy obesity, the hazard ratio for all the metabolic syndrome, the cardiovascular diseases and the cardiovascular events are around 1.4 or 1.5. But if you see the metabolically unhealthy normal weight, that is the normal weight individuals who have more of visceral adipose tissue or metabolically unhealthy, their hazard ratio is around 1.8 to 2. Whereas for metabolically unhealthy obesity, the hazard ratio goes to around 3 or higher. So there is definitely a progression from metabolic healthy obesity as the lowest category, followed by the metabolically unhealthy normal weight, and then the metabolically unhealthy obese individuals. The third point is whether this condition is progressive or not, whether it's static or progressive. But in these studies or meta-analysis, they've clearly shown that 57% of the metabolically healthy individuals or the metabolically healthy obese individuals and overweight subjects developed one or more cardiovascular risk factor or metabolic risk factors over 3-year period. And that goes still higher if we see the 6 years and the 11 years data, where they have shown that the hazard ratio significantly has gone up in progression to type 2 diabetes at 6 years follow-up and at 10 years follow-up. But definitely it is better than metabolically unhealthy individuals who are obese. So is MHO is progressive? The answer is very clear. It is yes, because if you see the normal weight individuals, then a small chunk of them, or around 20 to 30% of them, can progress to high risk in due course of time over 10 years. But if you see metabolically healthy individuals over 10 years, 50 to 60% will progress to metabolically unhealthy obesity. So it is not a static phenomenon, it's rather a progressive phenomenon. So the third point is when and how should we intervene? So should we treat a metabolically healthy obese or not? So this concept is very interesting, proposed by Dr. Nitin Kapoor et al. That we should see 4 aims for assessment of obesity. One is mental, mechanical, metabolic, and monetary. Metabolically healthy obese, they are all absent. So we are safe on that matter. But we have definitely concern about the mental health of the person who was obese though metabolically healthy, and mechanical aspect of this metabolically healthy obese individuals. So for that reason, the Canadian Society and the proposed clinical staging system for obesity, and that is known as the Edmonton Obesity Staging System (USS), which is a more which is a more comprehensive way of classifying different classes of obesity, and they have taken three important factors. One is medical, second is mental, and third is the functional. So even if for a metabolically healthy obesity the medical factors are normal, but definitely the mental and functional factors are playing a role, and that needs to be addressed, and they can go up to stage 2 or stage 3 also, and accordingly we have to manage. So this is how the USS staging system is there, and the MHO should be managed in a more person-centered manner, and USS has to be applied. And for stage 1 maybe a primordial prevention, stage 2 maybe a primary, stage 3 maybe a secondary, or stage 4 maybe a tertiary level of prevention is required, and so also the management strategies changes. This is another concept, that is the barophenotypic characterization, the key for person-centric obesity management, which very well comes into place when we discuss about the MHO phenotype, where we have to see the adipose topography, we have to see the barometabolic behavior, we have to see the comorbid conditions, functionality, and the enthusiasm and expectations. And accordingly, we have to sit with the patient and decide about the weight loss target and the weight loss pattern. And this is the current way of managing the metabolically healthy obesity. So first, any person who is obese who comes to us, we have to diagnose with either a novel definition or with the conventional definition, whether it's metabolically healthy or unhealthy. Then we advise them for healthy lifestyle modification. We target for weight loss, and if weight loss is achieved, it is good. If not achieved, then we can go for intensive lifestyle or weight loss medication, or even for a bariatric surgery. But having said that, there is a good concept that while in individuals with metabolic healthy obesity, 5% weight loss is sufficient to maintain a metabolic health. But for metabolically unhealthy obesity, probably we require more weight loss of around 5 to 15%, and accordingly we can use the drugs or the bariatric surgery for that. So with that, I'll come to the last slide, that is the conclusion. So metabolic healthy obesity is suspected when patient with obesity has no metabolic complications. Several pathophysiologic mechanisms have been described, and there are animal models to prove that, but its current day role in public health is dwindling, because it's not very clear what you should do for this patient, though there are various proposals, but it's not very clear cut. These patients may still have non-metabolic complications like the mechanical complications or the psychiatric complication that needs to be addressed in a more person-centric approach. The Edmonton obesity staging system and a barophenotypic characterization help to correctly assess the severity of obesity and prioritize the management. So with that, I'll end my acknowledgement to my dear friend Dr. Nitin Kapoor and the Endo Brigade for getting some of the slides. So thank you for the patient hearing.
Thanks sir, for eye-opening knowledge sharing of yours. Now the hall is open for questions.
Excellent option with.
Thank you.
So I have just query whether this metabolically, this health obesity, the blood reports are normal, all the metal. So do you think it's a compensated stage? Kind of, if you think this is a kind of frank diabetes, so it's a compensated with hyperinsulinemia. So whether these are actually a part of the pre-disease state or something like that.
I think we cannot tell it as a compensated stage, but we can tell it as a continuation phase actually. Maybe because we have seen around 60% or 57% will ultimately transit to a metabolically unhealthy obesity. So it's like a spectrum. So if I can give an analogy, probably pre-diabetes would be a better thing to give an analogy, because the way pre-diabetes progresses to diabetes, so also the metabolically healthy obesity will progress to metabolically unhealthy obesity. But again, it gives a window of opportunity where we can actually again revert back by reducing the weight. So that's why they've mentioned around 5% weight loss is better. But if you are unhealthy at the same BMI with metabolic derangements, then probably a 5 to 10% or even 15% weight loss is a better option. Just had to have one comment that actually people who are coming with this kind of situations, very difficult to understand those people that you are actually a part of the disease. So in near future you will be able. So only the
Right,
wet
right,
reduction
right,
is important.
right, right.
So anyone have any questions? No more questions. Thank you, sir.
Thank you. Thank you. Thanks a lot.
So for the next session on sarcopenic obesity, that is about emerging mechanisms and therapeutic options for that, I would like to call upon stage Dr. Nitin Kapoor sir, profession head of the Unit 1 CMC Velos, and needs no introduction although.
So, very good afternoon, and right at the onset, would like to thank the organizers for having me here today. In the next couple of minutes, I'll take you through this topic of sarcopenic obesity, emerging mechanisms, and therapeutic potential. And to make it more clinically relevant, I thought we'd start with a case and try and make the whole discussion of this particular talk like a case. So, a couple of days ago, I saw this patient who was a 56-year-old male. He's known to have type 2 diabetes for the past 3 years. And the only presenting complaint of that patient was, Doctor, everybody is telling me I look weak, I look thin, I look frail. And why is it so? And this patient has been to several doctors, and the only complaint is looking weak. Right. So this patient going a bit more in depth about the history of diabetes, known to have diabetes for the past 3 years, no macro or microvascular complications, been on metformin, on dapagliflozin 10 milligrams, sitagliptin 100 milligrams, no other significant past personal family history. BMI is only 22 kilograms per meter square. We're talking sarcopenic obesity, but the BMI is, by all definitions, within the normal range, though the waist circumference is high. No acanthosis, vitals are normal, systemic examination is normal. And this patient seems to have done a master health checkup somewhere, and they also have body composition analysis in that particular checkup, and somehow has come with a diagnosis of sarcopenic obesity. In that master health checkup, the dietitian is also seen and has told the patient, no, you have to, be on a strict diet and lose weight. And the patient is totally confused because patient is saying, doctor, I'm already so thin. Everybody's saying I'm looking thin and frail, and this dietitian is telling me to lose weight. And that's why I've come to see you all the way. The patient has several questions in his mind. He's a very well educated patient asking, what is this diagnosis that they have given me in this checkup? I never really, intended to do this particular test, but since it was part of a package, this is done. How do we confirm the diagnosis? Is this really common? Somebody else will also have such a thing. Is this the reason why I look frail? Is this the reason why I look weak? And should I be worried about it? Is there really a big problem that I'm foreseeing in the near future? And if at all, yes, then how do we manage it? So we'll try and address some of these questions as we go along this talk. So trying to understand what is sarcopenic obesity, and just taking up that point that Dr. Mittal sir mentioned about, we are seeing more and more elderly people in our society. This is called the gray wave or the gray dawn. Our life expectancy has gone up. In some states in India, it's as good as Western countries. And when we have more elderly people in our society, we are going to see more and more health problems, which are more common in the older population, be it diabetes, be it osteoporosis, be it obesity. And one of the attributes of age is that, as we age, our muscle mass tends to go down, our body fat tends to go up. So this is because of aging. Several mechanisms describe how that happens. It's been described because definitely the metabolic rate starts to come down. So definitely the body fat tends to go up. Our sex steroids, the hormones, especially in women after menopause and gradually in men, the testosterone starts to decline. So that is something which is important for the muscle, and that goes away. So again, there is muscle loss plus all the inflammatory cytokines, all said and done. At the end of the day, as we grow older, our fat percentage starts increasing and the muscle mass starts declining. And at some point, this itself becomes a vicious cycle. So if somebody's got obesity, that means they have a lot of fat. They also have a lot of intramuscular fat. And that intramuscular fat is also bad because it causes poor muscle quality, poor muscle strength, and the inflammatory markers ultimately lead on to sarcopenia. If somebody's got poor muscle mass, obviously they're not going to be exercising as a fit person would be. And that muscle fatigue, disability, low mobility again contributes to obesity. And this kinds of goes round and round and leads on to something called as sarcopenic obesity. But when we're talking to patients and trying to really make it simple for them, a 2 by 2 framework, something like this, where sarcopenic obesity would be somebody who's got low muscle mass and a high amount of body fat. Just the two components. Very simply, if we are trying to understand body composition, we often talk about the two compartment hypothesis, where we as physicians are interested in fat and everything else we put as the fat-free mass. So if my patient has high amount of fat and low amount of fat-free mass or predominantly low amount of muscle, we could say this is sarcopenic obesity. So this is two components, the fat and the muscle. The fat may sound simple, but unfortunately is not, especially in our setting, in the Indian setting, where we know that we have much more fat for a given body mass index. We also know that our population is prone to develop metabolic complications at much lower thresholds of fat, be it diabetes, hypertension, dyslipidemia. The study that we did in the cohort that we follow in Kerala showed that about two-thirds of the so-called normal weight people have high amount of body fat. The one-third of the entire population, when we look at the prevalence of diabetes, hypertension, dyslipidemia in these people, it's huge. And very recently, now that we've concluded the 10-year follow-up of this particular cohort, we find that these people with normal weight obesity do really bad by 10 years as compared to those who were non-obese. They do quite similar to the people who were obese at baseline. So yes, assessing body fat is difficult. The Endocrine Society of India guidelines tell us very clearly our BMI thresholds, which are definitely lower than the West, similar to what the WHO has suggested for the Asia Pacific region. So that's about the obesity part. But talking about the muscle mass, and again, assessing sarcopenia, which is again having three components. We'll talk about it in a little more detail in a while, but we're essentially looking at physical function, muscle strength, and muscle mass. And again, the cutoffs for the Asian population are slightly different as compared to the Caucasian population. But you see, this seems to be really tedious. Assessing all of these things in the clinic is often not very easy, and there is a working group for sarcopenia from the South Asian region. And again, more simpler tools have been proposed. Something as simple as using a calf circumference is a good indicator of assessing muscle mass both in men and women. There are other questionnaires as well, something called as the SARCF questionnaire. You see how simple it is. Just 5 questions. Every question is graded as 0, 1, and 2. If the SARCF score of a particular person is more than equal to 4, yes, that patient is at high risk of sarcopenia. Other anthropometric measures are also described. So long story short, our patient is asking us, what is sarcopenic obesity? In simple words, we can tell the patient, yes, you tend to have more body fat than what you should have, and your muscle mass is lower than normal. But how objectively can we tell that? If how can we reconfirm the diagnosis? And as I mentioned, for sarcopenia, we would have three components. We're trying to assess the muscle mass, the muscle strength, and the muscle function. So how do we do that? Well, there are several ways to assess muscle function, but probably the simplest way in the clinic to assess muscle function is to do a small walk test. If you have good space in the clinic, maybe 6-meter walk test, see the amount of time that the patient takes to just complete that walk. And again, for the Asian population, the cutoff, if the speed is low, means your muscle function is poor. This is just one of the components of sarcopenia. In addition, we also assess muscle strength. A hand dynamometer can be used. Again, there are cutoffs which are specific for the South Asian population. And again, they are much lower than the West. Talking about muscle mass, and yes, ideally you'd like to do a body composition. DEXA is something that we can do, but even the other bioimpedance analysis do tell us about how to assess the muscle mass. Yes, you have to make sure that when you're using bioimpedance, you use all the precautions that you need to, because even just probably half a liter of water would change that value. So the patient should make sure all the precautions are followed before getting onto the bioimpedance machine to try and understand the values. But yes, the appendicular lean by height square that is often given by these body composition machines would tell us whether the patient has poor muscle mass or not. And again, the cutoffs are different for men and women. If anyhow you're doing the body composition for the obesity aspect of sarcopenic obesity, you could also use body fat percentage. Again, the cutoffs are very varied. The Endocrine Society of India guidelines gives a simple definition of more than 25% of men and 30% in women is the cut point for abnormal amount of body fat in men and women. So with this background, let's look at the DEXA of our patient who is presented to us with this so-called frailty. And as I mentioned, the BMI of the patient that you see is just 22.3, and that is within normal range. But you look at the body fat percentage, the total body fat percentage of our patient is 41%. By all definitions, whether Western, Indian, maximum you can expect a normal body fat for a male is 25%. For a female is 35%. So this 40% is definitely very high. But when we also look at the appendical lean by height square, and that is also low, less than 5.5, and that would tell us that this patient has something like a normal weight obesity, but also sarcopenia and would fit in to the diagnosis of sarcopenic obesity. How common is it? Well, there are several studies which have been done globally and India, but the biggest problem is that these studies have used very different cut points for definition of sarcopenic obesity. The SarcoCubes led by PGI Chandikar was in younger population. Some of the Western studies that we have, again, you see the prevalence ranges from 4 to 12%. And that's the reason is that, the body fat percentage cutoffs, the muscle mass cutoffs are all very different in all the studies. So you need to look at that before you look at the prevalence itself. A couple of years ago, we were looking at a study of osteoporosis in geriatric patients with motor neuron disease, and we wanted a control to see how sarcopenic obesity is prevalent. And we didn't find any literature for the control, so we had to recruit the controls. And our prevalence in this elderly age group was 16%. More recently, looking at another national data set, the longitudinal aging study of India, and again, looking at the prevalence of sarcopenic obesity in this particular age data set, where the mean age is about 60 years, was 8.7%. But that's significant. 1 in 10, or maybe 1 in 12 elderly people in our society would have sarcopenic obesity. And that takes me to the next question. Is this really important? Is this something we as clinicians should be really worried about? Well, when we look at, again, data from different studies, this is a study for elderly men looking at follow-up data of about 1,700 people, mean age of 70 years, followed up for 5 years. And definitely, very clearly, they've shown that these people who have sarcopenic obesity have higher chance of admissions, higher chance of frailty, disability. Does it increase the risk of metabolic syndrome? The answer is yes. You look at the odds, 8.28. This is another study, 500 plus participants in the Korean longitudinal study being followed up for a good period of 5 years. And then you see that the odds ratio for developing metabolic syndrome is 8. Cardiovascular health, cardiovascular mortality, recently reviewed this literature. Again, that is very significant, be it knee arthritis, osteoporosis. And believe me, this is not that just because these people are elderly, so that's why the chance of osteoporosis and knee arthritis is high. These odds are based on comparison to same age people who do not have sarcopenic obesity. And it's just not about osteoporosis, it's about fractures as well. Whether it's non-vertebral fractures or vertebral fractures, they are much higher in these people with sarcopenic obesity. Even depression has been shown to be higher in these individuals. But I think one slide, if you really need to remember of all these different studies, is this slide, because this talks about the mortality. This is again a large data set, 4,500 people, people above the age of 60 years, follow up of 11 years. And if you just concentrate on this last bit of the graph, where you see that the biggest bar of mortality is for sarcopenic obesity. We talk so much about obesity. Well, obesity alone, the mortality is much lower than even sarcopenia. So probably sarcopenic obesity and sarcopenia are better predictors of mortality than even obesity. And so definitely this entity cannot be just brushed under the carpet and said that it's not important. It is something worth looking for, and especially as we have more aging people in our society, we should be looking for that. Moving on to the last aspect of my talk, how do we manage it once we've diagnosed it, once we understand it exists? There are three broad prongs of treatment. One is exercise, Second is diet. And third, we'll talk about the drugs. Exercise, yes. All along, we've been talking about resistance training, which is important for the muscle. Again, looking at data. Whatever data is available at this point in time is going to talk. It's just not resistance alone. It's a combination of resistance and aerobic, which is important for sarcopenic obesity because you have to tackle the fat as well. It's just not about the muscle here. Here you have to tackle the fat as well. Again, what has been shown, several, resistance exercises. Very recently, a study conducted by AIMS Delhi, yet to be published by Naval Bikram's group, looked at band exercises and how it improves the sarcopenia in Indian population, and very effective changes. So yes, these modalities are effective. If you're looking at the message that we need to give to our patients, we have to tell about regularity more than quantity. If they're able to do something daily, that's more important than doing a lot on one day and just not doing on the other day. Again, this is a graded approach. You can't just jump onto resistance exercise on day one. Believe me, these are elderly people. So you have to go step by step. First flexibility, then balance, then aerobic, then resistance exercise. Talking about diet, and again, this is different from obesity. In obesity, also, you give a hypocaloric diet, but here you have to couple it with a high protein. I think several obesity guidelines would also mention how protein intake is important for management of obesity. When we looked at our own data from the obesity clinic at CMC Vellore, we find that despite most of these patients with morbid obesity, they're consuming a lot of calories, but despite taking all these calories, they still don't meet up the amount of protein that we have to have. So yes, you have to reduce the calories, you have to increase the protein supplementation in some studies, at least the normal recommended amount of protein, 1.2 grams per kg per body weight. And calcium and vitamin D supplementation have shown again some data that it improves the sarcopenia a bit. Talking about drugs, at this point, we do not have many drugs. Yes, vitamin D is important. Vitamin D, like many other places, here also has shown to be helpful, again, from the ISBMR guidelines, very clearly define the definitions of what the vitamin D level should be in our elderly population. Again, 20 to 30 nanogram per ml is something that we would target. At this point, there are a lot of drugs. We are also doing some of these trials at Vellore. There are myostatin inhibitors, there are oral renin analogs. All of these are being tried in patients with sarcopenic obesity. But as of today, we do not have a drug to write on our prescription for this. And the main treatment is treating the secondary causes and essentially making sure that you offer good diet exercise. If the patient has hypogonadism, then again, treating that would help. But at this point in time, the landmark treatment would be only the diet and exercise. So, friends, with this, I will stop here. These are the questions that we really looked at in this particular talk. We described what is sarcopenic obesity, how both the components of assessing muscle mass and body fat are important, how we confirm the diagnosis by measuring each of the three components of sarcopenia and the body fat percentage definitions that we have for today. We looked at the comorbidities that are associated with this phenotype. And the important point, again, that I'd highlight is the mortality in patients with sarcopenic obesity is significantly higher, nearly double than people with obesity or only sarcopenia. So, yes, this is an entity to be worried about. Talking about treatment, we're talking of hypocaloric diet, but again with high protein, resistance, and aerobic exercises, regularity being more important. And in the pipeline, maybe in a couple of years, we should have very effective drugs as well. So with this, I would stop here, but would be happy to take any questions. Right. So the question is on protein powders, whether they will help in improving sarcopenia or not. Well, there are a lot of studies which have looked at the type of protein that should be used in management of obesity and sarcopenia, whether it should be vegetarian or animal-based proteins. If you ask me, the bottom line for all these, it's more vegetarian protein than animal protein that helps to improve the muscle mass because, again, the fat component is less. Protein powders only to be supplemented in those who are not able to meet their daily requirement by diet alone. I know with diet it is difficult in a vegetarian diet to give the amount of protein that we use. But again, the important message here is that we're not giving high protein diet. I'm just trying to get the amount of protein that the person should normally have, 1.2 grams per kg body weight, not a higher protein that is sometimes used in different other spheres of practices where they want to build up muscle mass and they give a whole bolus of large amounts of protein, which has detrimental health effects as well. So, yes, if the diet cannot meet, we do supplement proteins, but that's not a big subset of our population, maybe just 5 to 10%.
Thanks, Dr. Nitin. It's an excellent talk. So, routine supplementation with the vitamin D. So, do you think do it have a role in sarcopenic obesity?
So, absolutely. So, even without checking for vitamin D, as long as your patient has a normal calcium level, we would give them about 1,000 to 2,000 units. Believe me, again, we are talking of people here who are at the age of 60. So, yes, we do supplement vitamin D to most of our patients in our OPD who have a normal calcium. Without checking the calcium, I will not give. I don't always ask for a vitamin D because it is expensive for some of our patients. But yes, if the patient can do it, it helps. If you're looking at the hardcore data of giving vitamin D and how much is the muscle improvement, again, there is significant improvement, but I think the bigger benefit is for the bone. The second bigger benefit is for the muscle.
Sir,
Any other
thank
question?
you. Thank you for your nice deliberations. One question, please. That in case of sarcopenic obesity, where there is hypogonadism, do you think replacement of hormone is necessary?
Yes, so sarcopenic obesity per se is not an indication for hormone replacement, but yes, if there is hormone deficiency and it has to be replaced for the reason of hormone deficiency, if there is late onset hypogonadism where the male is symptomatic and the testosterone levels are low, if it is a premenopausal woman who has had a premature menopause, yes, you would replace hormones. You would anyhow replace hormone irrespective of whether the patient has sarcopenic obesity or not. But yes, that would improve the muscle mass. But I'm not going to prescribe testosterone and estrogen in people who have no indication of starting it otherwise, just because of sarcopenic obesity.
So, any more questions from the audience? No more questions, sir. Thanks for your excellent deliberation.
Thank you.
Thank you, sir. So, for our next topic, that is on metformin in pregnancy, it is comfort or concern. So, I would like to call upon Dr. Deep Datta, sir, from SIDA Super Specialty Healthcare, Delhi.
A very good afternoon to all. Uh, it's a big honor to be back to the one of the biggest endocrine updates in our country, the Crescendo 2024, organized by Endocrine Society of Bengal and my parent institute, the Department of Endocrinology, IPJMER. In the next 20 minutes, we shall be discussing the always burning question for many years now: metformin, should we be using in pregnancy? Is an area for concern, or is it a topic for something to worry about? I have no conflict of interest with regards to this presentation. This is especially important because, as we know, the society, we are becoming an obese society. So, as expected, the better half of the society will also be obese and they would be at a higher risk of GDM. And this problem is going to increase more and more in our practice. There's a global data which clearly shows that we South Asians, Indians are not doing great. 1 in 4 women in our country, the data shows, is going to face GDM during her pregnancy. It is maybe even 1 in 3 so in case of uh, Middle East. But in real practice, where I practice in Delhi, where it's rare to see a normal BMI person, I think 50% of all the pregnancies we have a challenge in managing blood glucose. That's the ground reality. So it's a problem. We recently published a systematic review which looked at we talk of GDM as something we diagnose at 24 to 28 weeks of gestation. But in nature, everything is a continuum. The nature doesn't wait for us to 24 weeks for the hyperglycemia to take place. And we looked at the data. What about the early pregnancy, the first trimester, first 12 weeks? What happens if the blood glucose start going up then? We know that the diagnostic criteria of GDM and the treatment targets are different. So we use the treatment target. So we found that in first trimester of pregnancy, if the fasting blood glucose is more than 92, there's a higher risks of GDM later in the pregnancy, higher risk of pregnancy-induced hypertension, the higher risk of large for gestational age and macrosomia in the born kids. And if the fasting glucose crosses 100 in first trimester of pregnancy, the hazards ratio actually go up even more. Again, to highlight that it's we are never too late. I mean, we should pick up as early as possible. Quoting Dr. Yagnik, he is almost considered the father of transgenerational medicine in our country. He says if you really want to handle GDM, pick up the couples before conception and act on them to ensure not only euglycemia, the whole metabolic profile. Because if you look at it, if a lady who is having diabetes in pregnancy or GDM, and if she's carrying a girl child in her womb, and if that girl child, the first meiosis in her ovaries is taking place when she is inside the uterus of her mother. So when we are talking of blood glucose control in pregnancy, it is not going to affect the next generation. The first meiosis is already completed in the ovary. The grandchildren are going to be affected. So that is the extent of the problem. If you want to prevent the adverse outcomes, you have to start acting 2 generations before. That's the ground reality. We know that the pillars of managing GDM has been medical nutrition therapy, diet and lifestyle changes, exercise, and then comes insulin. So we talk of typical GDM, which is the more uh, less virulent form, which typically comes after 24 to 28 weeks of gestation. There, a majority of the patients we are able to manage with good diet and lifestyle changes, and of course, there is insulin. But what about metformin? Should we give or not? I think if you look at the physiology, pregnancy is a state of physiological insulin resistance. So if you have something is not working, if you pump in extra insulin, of course, we will control the blood glucose, but the main issue is not being addressed. And metformin is the only drug which has been used since 1970s in pregnancies, and it is a great insulin sensitizer. We all are using metformin in different permutation and combinations in GDM or diabetes in pregnancy, pre-existing diabetes in pregnancy. And the story started way back in PCOS. A lot of PCOS women were receiving metformin. We know that giving metformin improves fertility in women living with PCOS. And not only that, there's good data to show that women with PCOS, when they conceive and they continue metformin in first trimester, chances of miscarriage are actually lower in them. So showing that it is safe in first trimester. The funny thing, the ADA 2022 guidelines said that you in women with PCOS use metformin till the end of first trimester and stop it. The entire organogenesis took place in the first 12 weeks. What are you going to achieve after stopping after 12 weeks when actually the physiological insulin resistance is going to further increase and it peaks around 30 to 32 weeks of gestation? So even the guidelines are pretty much confused. I shall come to it later. So I think we use metformin in different permutations and combinations. You can use after diet and lifestyle changes, or you can add it to insulin. Advantages: when you add to insulin, it helps in keeping the total daily dose of insulin to manageable limits. It helps in reducing the glycemic variability. We know that treatment targets are so strict that often do patients do face hypoglycemia, and to ensure that they keep all their fasting blood glucose, the pre-meal values less than 95 milligrams per deciliter, or 2 hour post-meal values of less than 120 milligrams per deciliter. In a nutshell, metformin makes life easy not only for the patient but also for the treating doctor. So let us look at the different guidelines. Just to highlight that the ADA guidelines is pretty confusing itself. The ACOG guidelines are more pragmatic and more rational, and they are more acceptable to use of metformin in pregnancy. And if you look at the NICE guidelines, the UK people are very pragmatic in that case. The NICE, the government pays for everything, and they have. So if you're really confused with any guidelines, look at the UK guidelines, NICE guidelines. They are totally clear that they prefer using metformin in pregnancy and in after diet and lifestyle changes, and then you add insulin later. So the question remains that yes, we are going to use insulin, but if I say metformin should be used in all pregnancies with diabetes, I would be wrong. If I had said we should not be using metformin in pregnancy with diabetes, I would be totally wrong. The key is to find the good clinical practice. Who are the right patients where to use, and who are the right patients not to use metformin. So there is a lot of systematic reviews published for the initial outcome, the first 2 to 3 outcomes. We published the first systematic review looking at the safety of metformin used in pregnancy. So some group of mothers who received only metformin in pregnancy compared to a group of mothers who received only insulin during pregnancy for managing the hyperglycemia, and what happened to their kids and to them, to the mothers, 5 to 11 years after childbirth. If you look at the data, the green highlighted area, if you see here, it showed that at 9 years after childbirth, there was no difference in body composition parameters of those kids. If you are looking at the subcutaneous fat, if you look at the whole body fat, the muscle mass distribution, the visceral fat distribution, and even when MRI was used to look at the hepatic fat content, it was not different in the kids who received whose mothers received metformin during pregnancy 9 years back as compared to kids whose mothers received insulin. Not only that, even at 11 years after pregnancy, the occurrence of diabetes, the occurrence of obesity in the mothers were not different. Even childhood obesity was not different, showing that even we now have a good data even after 11 years of safety of use of metformin, even after 11 years of childbirth. So of course, the systematic review is as good as the data you analyze. So these were the 5 major cohort of patients we looked at. If you look at the profile of the patient, all these mothers in those studies were in their early to mid 30s. And if you look at their BMI, they were all more than 30, even 32, 33. So, so they were all overweight to obese. So if we are using metformin in women with obesity in pregnancy, we are really going to improve the outcome. That's the key message coming from this systematic review. A limitation also I'd like to highlight, of the 10,000 odd mother-child pairs we analyzed, 9,000 came and around nearly 9,000 came from one cohort. So they were, and all other cohorts, the 4 cohorts were pretty small, showing that we need more studies so that we have more robust data. We don't have any Indian data, and why we need Indian data is important. This from the discussion of the same paper, we showed that in India, we do have a lot of lean pregnancies, especially if you're moving out of the metros to the villages, the semi-urban or rural areas. So lean women, underweight women are more likely to have small for gestational age kids. So we should be cautious for using metformin. The advantage of metformin lies in an overweight mother. If we are using metformin, it reduces the risk of macrosomia. It reduces the risk of large for gestational age. So at the same spectrum, if child, a baby who is going to be was born to be a normal or slightly no normal, lower side of normal body weight, if you use metformin, they would have a higher risk of small for gestation age. So a good clinical practice would be, the data also shows that in mothers who has had history of preeclampsia, eclampsia, proteinuria, nephropathy, multiple comorbidities, those who are lean, these are the specific pregnancies where if you use metformin, we are going to increase the risk of small for gestational age. Apart from that, the simple plain Jane type 2 diabetes or obesity induced GDM, we can happily and safely use metformin. Let me share the data from our center we published 5 years back. 5,000 odd patients who walked into a clinic, we measure their anthropometry regularly. If you see a normal BMI, which is defined as 18.5 to 23 kilograms per meter square, where only 18%. So in Delhi, in West Delhi, where I live, it is normal BMI people are endangered species. When I lost weight recently, patients started asking me, Doctor, are you fine? Are you sick? One even told me, Doctor, apni TB check kara lo. So there's a social acceptability of obesity. Obesity has been considered as a norm. So if you look at somebody's normal BMI, it's considered abnormal. So we need to cross these barriers in our society also. And when we talk of diabetes in pregnancy, it's just a reflection of the societal prevalence of insulin resistance and obesity. Now, let us look at the smaller trials. I showed the data of 5 to 11 years. There are much more trials published for shorter outcomes. The immediate outcomes and 2 to 3 year outcomes of use of metformin versus insulin in gestational diabetes. They all clearly showed here. This is the MIC trial I'm specifically showing because this is the trial which let the cat out among the pigeons. It showed that the risk of preterm delivery was higher. If you see the overall value, less than 37-week gestation was 0, P was 0.04 overall. But if you remove the iatrogenic cause for preterm delivery, maybe the doctor has had some reason, oligohydramnios, whatever the gynecologist felt. If you look at spontaneous preterm births, it was not significantly improved in the group of mothers who received metformin as compared to group of mothers who were treated with insulin. Again, showing that if you look at the data the right way, the metformin was safe. And in the same trial showed that all the secondary outcomes, if you see, there was a benefit with use of metformin as compared to insulin. The only way area is that, of course, They have the slightly increased risk of small for gestational age kids, newborns. And we just discussed what are those risk factors, what are the red flags where we should not be using metformin. Again, it showed that mothers who were obese to start with, a greater amount of obesity to start with, and mothers who had onset of dysglycemia earlier part of the pregnancy, they had a more fulminant GDM, mean they had to be added insulin also to metformin, again showing that the nature of disease was more aggressive to start with, and that's why you needed multi-drug therapy and not just metformin for managing, I mean, you call it early GDM or pre-gestational diabetes, whatever you may want to call it. This is a good systematic review looking at the immediate outcomes. 21 RCTs were analyzed. If you see here, metformin wins over insulin in terms of preventing excess maternal weight gain, in improving the gestational age at the time of birth, reducing the risk of gestational hypertension, the birth preventing macrosomia enlarged for gestational age, even the risk for ICU admissions were reduced with the use of metformin. So only where insulin wins over metformin is the cohort of patients who are at high risk of small for gestation age, small built mothers, small fetus. We need more anabolic hormones. Ideal scenario where insulin would win over, because insulin itself is an anabolic hormone, unlike metformin. So there's another systematic review I would like to highlight, which compared metformin, glibenclamide, and insulin. Clearly shows that metformin wins hands down over in terms of improving the fetal and the maternal outcomes. And of course, glibenclamide comes last. And of course, none of us are using glibenclamide now for managing diabetes in pregnancy or gestational diabetes. So the summary is that yes, the larger maternal and fetal outcomes in terms of preventing large baby and all the complications associated with large baby are taken care of metformin, which is not possible with insulin. Of course, in mothers who are at risk for small for gestational age for any cause, insulin wins hands down. In that cohort of patients, we should avoid metformin in them. I think Mick Tofu study also talked the same thing. This showed that in mothers who use metformin at 2 years of age, when they did the anthropometry of the kids, peripheral fat, the fat in the arms, upper arm circumference, tricep skin fold thickness, subscapular skin fold thickness was slightly higher, but visceral adiposity, which is the dangerous form of fat, which is more inflammatory fat, that was not increased with the use of metformin in these kids as compared to mothers who had received insulin in the pregnancy. So this study, we already discussed the 7 and 9 years outcome, the Auckland study in our systematic review. So I'm not going into it. I would just like to highlight that metformin addresses the various issue. How does metformin work? Metformin reduces appetite in the level of mother. The intake of calories goes down. Metformin crosses, the fear was that metformin is a drug which crosses placenta totally. So any drug which crosses placenta is going to do harm. That we have seen, it doesn't does that. It doesn't work that way. And when we talk of as an extension lactation, metformin is very rarely found in extremely low levels in breast milk. So it's totally safe for mothers on metformin to breastfeed their kid. That's also important. Metformin acts by different pathways. mTOR pathway is something it is believed to work on by it prevents the reduces the energy consumption both at the level of mother, also at the level of fetus. So if you want to say metformin is largely a hero, it would be a villain only in pregnancies in small weight mothers, underweight mothers, lean mothers who are at risk for small for gestational age kids. There's a very beautiful paper which came in Diabetic Medicine, which beautifully highlights the key message that metformin has been used in pregnancies in 1970. It has stood the test of the time. It makes life easier for both mother and child. Concern exists around risk for only small for gestational age. There is enough data to show metformin does not cause any congenital malformations. So in those women who are at high risk for SGA, please do not use metformin or avoid using metformin in them. We would just like to show one of our new systematic reviews, which is going to come online very soon. We showed one review, we showed that even early pregnancy hyperglycemia in the so-called normal age range can lead to an over GDM in late pregnancy. So what happens if we treat early GDM? Yes, if you treat early GDM in the first trimester of pregnancy, you can still improve the fetal outcomes. And here the risk for neonatal respiratory distress was significantly lower in mothers who were picked up at early GDM and were treated appropriately for early GDM. So I would also like to highlight Dr. Nitin is here, a paper from his institute. They beautifully showed we have some good Indian data showing from CMC Vellore. They had 3 cohorts of patient. Group A they received only metformin. The women received only metformin in pregnancy. The group B received metformin in the second and third trimester. Group A received in the first trimester, and group 3 received insulin at different points of time. And they in detail looked at all the different neonatal parameters and maternal parameters, and they showed that metformin is safe and worked great when initiated both in first as well as in second or third trimester of pregnancy. So yes, we have good data published in the official journal of IDF, which is Diabetes Research and Clinical Practice. I would like to highlight again the end by highlighting the NICE guideline, which clearly supports the routine use of metformin for managing hyperglycemia in pregnancy because it addresses the core physiological issues. Even our Ministry of Health and Family Welfare, Government of India guidelines also clearly supports the use of metformin or in both along with insulin or alone for managing hyperglycemia in pregnancy. So we are medical legally also, we are very safe. And the comfort, there is a definite comfort on that part of patient. There are a lot of studies which have looked into the quality of life of mothers who have received metformin versus insulin. All of them voted overwhelmingly in favor of metformin. There's comfort not only in terms of ease of taking, comfort in terms of ensuring a good glycemic control with lesser glycemic variability and improving the fetal and maternal outcomes. The red flags I've already highlighted for you. Thank you so much.
Thanks a lot, sir, for your excellent deliberation. So, if there any question from the audience?
What type of insulin should
Yes, I think the guidelines are very clear. We are typically using, if you look at hyperglycemia pregnancy, controlling the postprandial hyperglycemia remains a bigger challenge as compared to simple plain type 2 diabetes. So we are using a basal bolus insulin mostly in our patients with diabetes in pregnancy. Of course, it's a spectrum disorder. Some of them having mild diabetes, you may even give a pre-mixed insulin also once a day or twice a day, depending on the SMBG chart. Many of these patients, we have to put them on CGM to look at the fine tuning because the treatment target is to keep HbA1c 6% and not 7. And trust me, it's a big challenge to ensure a 6 HbA1c throughout the entire pregnancy.
Is there any question?
How good is metformin to continue in a prospective cesarean delivery?
So as there's data to show that when women with GDM who received metformin, the risk, the need for cesarean delivery was also reduced in that systematic review of 21 RCTs. So there is no harm in continuing metformin. Of course, on the day of surgery, the patient is going to be NPO. So at that time, we are not going to give metformin. We are then going to put the patient insulin infusion based on the blood glucose values.
Just 1 to 2 days following delivery, post CS delivery, whether it will be better to replace the metformin by insulin?
So post-delivery depends what was the nature. It was a simple GDM. We started at 28 weeks of gestation. Most likely the baby is out, the resistance is gone. They don't need medicine. It was a pre-gestational the type 2 diabetes. Of course, in this patient, once they are on oral food, we can happily restart metformin.
Okay.
So if a GTM patient is controlled by MNT only, how frequently would you advise for blood sugar estimation?
Well, that's a great question, sir. Because yes, we have to sustain it till 38 weeks of gestation. There's a lot of fatigue involved in pricking. Costs are also involved. In a person on medical nutrition therapy, I typically ask them to check at least twice a day. Maybe some days they can check fasting post breakfast. Next day they can check a pre-lunch, post-lunch. Next day they can check a pre-dinner, post-dinner. So you get a good pattern over 1 week. If the blood glucose value starts going haywire, you do more intensive control. You add metformin or insulin, and if it's doing pretty well, then perfect. Continue the same.
What can be the maximum dose of metformin that can be used?
Typically, what we are using in managing type 2 diabetes, we typically use till 2 grams. We rarely cross more than 2.5 grams. Nothing like that. Yeah.
So again, before conception can help physiology and lady has conceived. You suggest conceive that one whether there the blood sugar is normal. We assume that metformin is for the pregnancy.
So if the blood glucose is totally normal, HbA1c is coming 5.2, 5.3, then why should we continue? We can of course stop the medicine. Totally individual basis, patient centric. Absolutely.
That I'm asking whether after the conception the placebo is normal, metformin should be considered.
That's it depends on the blood. If patient is having hypos, we have seen hypos with metformin also. The blood glucose is going down. Patient is having GI problems. First time say the high threshold for having low threshold for having GI problems. If they're having hypos, not tolerating it, stop it. It's not like we have to give it. It's totally patient centric how the patient is handling the dose at that point of time.
A roll of metformin with sitagliptin or dapagliflozin to reduce the HbA1c.
So we are not using sitagliptin and dapagliflozin in pregnancy. So that's we are not using. It's very clear. We should not be using it.
To reduce the HbA1c.
So when we are talking of pregnancy here, sir, we can't use that, sir.
Now, some information knows that the HbA1c is reduced by this drug.
They will reduce HbA1c, sir, but we don't have the safety data. That's why we are not using in pregnancy.
Only metformin?
Yes, and insulin, nothing else, sir.
Only insulin.
Yes.
Okay.
More questions.
Insulin, regarding insulin administration, basal insulin, glargine, detimir, anyone can be used. And in case of soluble, human actropid or rapid acting other insulins, anyone can be used.
Yes, sir. We have been using NPH since time immemorial. We have been using Detimir for a long time because we were told that if a patient on glargine, you can continue glargine. You should not be initiating glargine. But now we have data showing clearly you can initiate glargine also. If you want, you can even initiate degludec insulin also. You can use any of those human insulin regulars. You can use the shorter acting like aspart, lispro. You can use as a part of your treatment regimen, sir.
I hope there is no more questions, sir. Thank you, sir.
Thank you so much.
Okay, so for our next and last session on rash blockade in advanced DKD, I would like to call upon stage Dr. Santosh Ramakrishnan, sir, for Magna Centers, Hyderabad.
So I can see that I am the only person who's standing between you and lunch. And I'll tell you a cheat code. I've already had my lunch, so I am okay with it. If anybody's feeling hungry, please free to leave. No problem. I won't feel bad. So I'll be talking about RAS inhibitors in advanced diabetic kidney disease. So what I'll be discussing today is what is the definition of diabetic kidney disease? What is the role of the renin angiotensin aldosterone system in diabetic kidney disease? How the RAS inhibition, how it helps in diabetic kidney disease, and what we should be doing in advanced diabetic kidney disease. So what is diabetic kidney disease? So diabetic kidney disease by definition is the decrease in the EGFR of a person with type 2 diabetes with or without albuminuria. Whereas diabetic nephropathy, it goes more of the classical way. It moves from microalbuminuria to macroalbuminuria to EGFR decline when characteristic pathophysiological features will be there. That is, there is increased mesangial substrate, nodular lesions, and tubular interstitial fibrosis. Now, if you look at diabetes and the kidney, how prevalent is CKD in diabetes in kidney? It's very common. So if you look at the prevalence of diabetes in the world, it's 537 million people with diabetes as far as IDF 2021 is concerned, out of which more than 40% of the people will develop diabetic kidney disease at some time of their life or the other. And diabetic kidney disease accounts for 50% of those patients who are undergoing end-stage renal disease. The diabetic kidney disease is classified with using this heat map. So heat map means there is a worsening degree of albuminuria, 30 to 3, less than 30, 30 to 300, greater than 300, or there is a worsening degree of decline in the EGFR, that is less than 90, less than 60 to 90, or 45 to 60, or 30 to 45, 15 to 30, or less than 15. So the worse the decline in EGFR and the worse the albuminuria, the worse is the risk of the patient for cardiovascular disease and end-stage renal disease. Now, if you take the natural history of diabetic kidney disease, it looks like this. So in the initial few years, you might not be able to pick up diabetic kidney disease because it's a subclinical disease. There is a
In stage 1, there is hyperfiltration, no microalbuminuria. In stage 2, the hyperfiltration comes down and albumin excretion ratio just starts beginning. Most of the patients we pick up during stage 3 of diabetic kidney disease, when albumin excretion ratio starts increasing, but the creatinine has not started increasing as yet. In stage 4 diabetic kidney disease, there is overt diabetic renal disease in which there is micro to macroalbuminuria and declining EGFR, and stage 5 obviously is end stage kidney disease. Now, if you look at the pathophysiology, we'll remember that this is the most difficult subject in the entire MBBS, is it not? Pathophysiology of any particular illness. So if you have to make it simplified, we have to see that there are 3 things that fall in the pathophysiology of diabetes kidney disease. One is metabolic dysregulation. That is, higher the sugar, higher the lipids, higher the abdominal fat, there will be increase in the reactive oxygen species, advanced glycation end products, protein kinase pathway, hexosamine pathway. Therefore, if you control the blood sugar of a patient and you control the lipid profile of the patient, you will be preventing diabetic kidney disease. The second problem in diabetic kidney disease is inflammation and fibrosis. Inflammation and fibrosis mainly occurs due to activation of the mineralocorticoid receptor in macrophages, and therefore the new drug finerenone is now being used because it is a selective mineralocorticoid receptor antagonist. So therefore finerenone is helping. So blood sugar control, statins and finerenone. So where do the ACE and ARB inhibitors, where do they come actually? So they come in helping in reducing the hemodynamic perturbations. And I'll be talking about them a little bit later. So if you remember the definition of diabetic kidney disease, when we used to learn when we were in MBBS days, MD days, we used to say that if a person is having a kidney related problem which is associated with retinopathy, then we should think about diabetic kidney disease. After some time, we came to know that if a patient is having albuminuria, it is a surrogate marker for cardiovascular disease. But right now, we know that diabetic kidney disease does not occur in isolation. It occurs with so many other problems. It occurs with diabetic eye disease, erectile dysfunction, neuropathy, bladder dysfunction, foot disease, peripheral vascular disease, coronary artery disease, cerebrovascular disease, cognitive impairment, etc. So much so that if a person is having diabetic kidney disease, the 10-year mortality increases significantly. So look at this graph. If you can see that in patients with diabetes but no kidney disease, the 10-year mortality is only 4%. With albuminuria, it's going up to 17%. With impaired GFR, it's going to 23.9%. And in those patients who have albuminuria and decline in eGFR, only 47% of the patients will not live past 10 years. So this is making it a dramatic complication for diabetes. And we as physicians, endocrinologists, and general practitioners, we should make a difference in the patient's life by helping to prevent progression of this illness. Important part of this slide is in patients with diabetic kidney disease. The reason why they pass away is not usually because of electrolyte imbalances or lack of dialysis. Most of them, they pass away because they have cardiac illness simultaneously, which is getting worsened because of the presence of CKD. Cardiac death is the #1 cause of mortality in patients with CKD because coronary artery disease, LVH, valvular calcification, valvular damage, asystole, bradyarrhythmias, all these things are occurring with much higher frequency in those patients with CKD, and majority of the patients are actually dying because of cardiovascular related problems rather than worsening kidney disease. Now we'll go back to the renin-angiotensin system. So what do we know about the renin-angiotensin system? Now, in the presence of diabetes, there is hyperglycemia, and the excess glucose gets filtrated by the glomerulus into the tubules. In the tubules, there is one enzyme, that is the transporter. The sodium glucose transporter is there. The sodium glucose transporter, what it will do, it will take away the extra glucose along with the sodium into the blood, leading to a decreased delivery of sodium to the macula densa, and macula densa will send a signal to the juxtaglomerular apparatus to release renin. So this is a revision of our physiology class. Renin will act on angiotensinogen, which is coming from the liver, and it will convert it to angiotensin 1. Angiotensin 1, while it is going through the pulmonary circulation, it will get acted upon by angiotensin converting enzyme to angiotensin 2. And angiotensin 2, we used to think that it acts only in the mineralocorticoid activity. Basically, it increases the aldosterone is what we thought. But angiotensin 2 actually causes so many other changes in the body also. It causes vasoconstriction, it causes ADH release from the pituitary, it causes fluid and water retention, fluid and solute retention from the kidney, leading to a myriad of effects of angiotensin 2. The biggest problem with angiotensin 2 is while it is doing all these things, it is also causing inflammation and fibrosis everywhere. So it is causing mainly in the heart and in the kidney, it is causing inflammation and fibrosis. So much so that if the renin angiotensin aldosterone axis gets hyperactivated, either in the systemic way or in the level of kidney, there are so many changes that are occurring. There are some people who said that only renin itself is deleterious. So renin can cause non-enzymatic enhancement of angiotensin 2, mesangial hypertrophy and renal fibrosis. There was a company which introduced aliskiren. If you remember, there was a drug called as aliskiren, which was a direct renin inhibitor. But unfortunately, it did not show much mortality benefits, and therefore aliskiren is no longer available. So we are now concentrating not on renin angiotensin inhibitors, but how we should help in reducing the angiotensin 2. Angiotensin 2, as I said, it causes numerous damages in the kidney. It increases the intraglomerular pressure, water and solute retention, renal fibrosis, glomerular and tubular interstitial inflammation. So aldosterone 2 is one of the major components in the mechanism of diabetic kidney disease. There is an effect of local renin angiotensin in the kidney also. So not only what is happening in the blood, even locally angiotensin 2 is causing damage in diabetic kidney disease. What does angiotensin do exactly? So angiotensin do, what it does is it causes efferent arterial vasoconstriction. So if there is efferent arterial vasoconstriction, there will be hyperfiltration at the level of glomerulus, along with increased blood sugar, increased reactive advanced glycation species, reactive oxygen species. The hyperfiltration is causing continuous damage to the glomerular endothelium and the basement membrane, leading to diabetic nephropathy and its associated changes. So now RAS inhibition in DKD. So what are the RAS inhibitors that are available? The angiotensin converting 1 enzyme, ACE inhibitors, which are inhibiting the ACE at the level of pulmonary endothelium, and the angiotensin receptor blockers. So ACE inhibitors we know are captopril, ramipril, enalapril, whereas the angiotensin receptor blockers we know are losartan, telmisartan, olmesartan, irbesartan, which we are using in our day-to-day practice. It was in 1993 that the first paper with ACE inhibitors got published in NEJM, and they showed that the effect of captopril in preventing diabetic nephropathy in type 1 diabetes was tremendous. So this was a huge data at that time, because till that time we could not do much for patients with diabetic nephropathy. Once ACE inhibitors came with this paper, it came with a bang. It shows that there is a reduction of proteinuria, there is a reduction in doubling of serum creatinine, and reduction of percentage of patients undergoing hemodialysis, making it a wonder molecule at that particular time. The angiotensin receptor blocker study came in 2001 in NEJM. The renal study came and showed that in patients with type 2 diabetes, losartan was doing the same wonders in what ACE inhibitors was doing in type 1 diabetes, and showing without fail that ACE and ARBs were excellent drugs in preventing the complications of diabetic nephropathy. And these are only 2 studies which I have quoted. Of course, there are more than 80 to 85 studies which shows that ACE and ARBs are beneficial in diabetic kidney disease. Then a little bit of battle started. ACE inhibitors are better or ARBs are better? So a little bit of battle started. This company started fighting with that company, etc., etc. But finally, scientifically, we could not find out any difference in the mortality benefits when either ACE was used or ARBs was used. Only thing, ARBs, they cause less side effects. So ACE inhibitors, we know they cause angioedema, sore throat, they cause a little more of hyperkalemia, whereas ARBs don't cause that much of side effect. Therefore, more and more of ARBs are being prescribed, losartan, telmisartan, irbesartan, whereas the number of patients who are using ramipril, captopril have come down. We still use them in type 1 diabetes, but the data as far as their efficacy is concerned, both are equally good. Now, the effect of ACE and ARBs have found to be so good that the kidney guidelines, the KDOGO guidelines say that in patients with diabetic nephropathy, the first line of treatment is obviously lifestyle, diet, exercise, prevent smoking, lose some weight. But as far as drugs are concerned, there are 4 things that you have to keep in mind. 3 things. So one is good blood sugar control. And when you want to control the blood sugar, use SGLT2 inhibitors, because we know with lot of data that SGLT2 inhibitors are very good for kidney related problems. I'm not going to discuss that today. Second is good blood pressure control and reduction of albuminuria. And that we know number 1 drug is in fact either ACE or ARB. And good cholesterol control, that is with statins. Now, if improvement is not there in the albuminuria, you also add a mineralocorticoid receptor antagonist. For BP control, you can use a calcium channel blocker. For diabetes, you can use GLP-1 receptor, metformin, etc. So, but the important thing in this slide is, in the number 1 treatment for diabetic nephropathy, as far as medications are concerned, ACE and ARBs are there, right there. Now, problem with ACE and ARB is what? Now, once you give an RAS inhibitor, the efferent arterial vasoconstriction will get released. And therefore, the glomerular filtration will come down after giving ACE inhibitors. So if the filtration comes down, what will happen? There will be a little bit increase in the creatinine after starting ACE and ARBs. So that has to be explained to the patient. So unless we explain to the patient will get scared. The patient will say, after you gave me medicine, my creatinine started increasing. So we have to explain to that patient at least in one line that your creatinine will increase by little. Don't worry about that. It's actually protecting your kidney and your heart. If the creatinine increase is very high, that it has gone to more than 30% of the baseline value, then there is something wrong. It might be acute kidney disease, or it might be a renal artery stenosis, or something else might be happening. So usually the creatinine increases, but it doesn't go above 30%. The second problem is hyperkalemia. So after 2 weeks, when you check the potassium, if there is hyperkalemia, check for other reasons for hyperkalemia and add diuretics if necessary before taking a decision of stopping the ACE and ARBs, because they are preventing the diabetic kidney disease. Now, what about advanced diabetic kidney disease? Now we are reached, the EGFR has gone to below 30. Should we be continuing ACE and ARBs? So the actual problem came when I told you, right? So when you start ACE and ARBs, because of the prevention of the efferent arterial constriction, the filtration is coming down. Therefore, when in the low EGFR, when you discontinue the RAS inhibitors, the creatinine seems to improve actually. And this paper which came in 2009, it showed that in those patients with advanced diabetic kidney disease, if you stop the renin-angiotensin inhibitors, the creatinine is actually increasing in such a way that almost 50% improvement might be there in some cases. So if a creatinine is, for example, EGFR is, for example, 12, it might come up to 18 also if you stop the angiotensin receptor inhibitors. Now, this was a time when in 2009, okay, so in 2009, we never used SGLT2 inhibitors because they were not there. We used to not give high intensity statins. Blood glucose control was done with only 2 or 3 drugs. So we really didn't know what is the reality over here. Let us fast forward to 2022. So this is a paper which is published in NEJM, and NEJM did, these people did the same thing. So when the EGFR came to less than 30, some people discontinued the RAS inhibitors, and some patients, they continued the RAS inhibitors. But in 2022, because of use of so many other beneficial drugs like SGLT2 inhibitors, high intensity statins, etc., they did not find the same change. They did not find a worsening of serum creatinine or a further decline in EGFR, even after the RAS was continued as compared to those people who did not continue them. The need for renal replacement therapy was not increasing in those people who were continuing RAS inhibitors. And in fact, the number of patients who were having a cardiovascular event were more in those people who stopped the RAS inhibitors. Now, this study was not actually to look at cardiovascular events, but this they found as a secondary analysis. This is a study from Japan. Now you can see the sample sizes increased 717, out of which they all went into hemodialysis. Out of 717, 650 patients continued the RAS inhibitors, 67 discontinued the RAS inhibitors, which was decided by the nephrologist, of course. And what was seen is those patients who continued the RAS inhibitors, their cardiac mortality was much lesser as those who discontinued them. Another study with 3,909 patients. They compared the mortality of stopping RAS versus not stopping RAS. And they found out that the mortality was higher in those patients who had stopped the RAS inhibitors as compared to those who had continued them. And this was the last study which I'll be quoting today, is with 10,254 patients. Half of them have discontinued the RAS inhibitors, half of them have continued the RAS inhibitors after their EGFR has gone to 30. It was shown that in those patients with RAS inhibitor continuation, they had lower mortality, they had lower cardiovascular events, and probably the kidney replacement therapy was a little bit more, but it was not statistically significant. So the conclusion is that discontinuing the ACE and ARB might actually be harmful for this group of patients rather than beneficial. So we should not use a standard formula. If EGFR goes to below 30, stop the ACE and ARBs. We should concentrate on the other aspects, because when the EGFR is going to below 30, we are not only worried about creatinine, we are worried about cardiovascular events, and continuing the RAS and the RAS inhibitors will prevent in cardiovascular events. As shown in my final slide, we don't have a lot of evidence to say that we must or we must not continue RAS inhibitors. But what we know for a fact that if you continue the RAS inhibitors in established diabetic kidney disease, you are able to prevent cardiovascular events and death, which is a very important outcome finally in a patient with kidney disease. That's all. Thank you.
Thank you, sir, for your excellent deliberation. So, may I ask if there is any question from the audience?
Sir, with advancement of kidney disease, there is usually there is hyperkalemia. In that case, ARBs or RAS, it is to be continued.
Hyperkalemia, if it is there, as per the guidelines, they say that you should first try to give potassium binding drugs, or you should give a diuretic, which will help in reducing the potassium. If even after doing that hyperkalemia persists, stop the RAS inhibitors.
Sir,
Choice
how
and
effective
dose
is
of
RAS blockade in non-proteinuric diabetic kidney disease?
In non-proteinuric diabetic kidneys also, the effect is shown very well for RAS inhibitors in preventing the diabetic kidney disease. There's a lot of data is there.
choice of anti-lipid therapy and dosage in CKD with or without dialysis.
So anti-lipid disease, of course, we have to use our clinical judgment, but the drugs of choice still remain statins, because we have enough good data with statins that they prevent cardiovascular disease and worsening of renal disease. Of course, the concerns remain is if they develop, what happens if they develop rhabdomyolysis? What if the CPK increases very much? Then we have to use our clinical judgment and stop them and give other drugs such as.
No, I was asking for whether it is rosuvastatin or atorvastatin.
With statin.
Yes.
So data is good with both atorvastatin and rosuvastatin. It's a little bit robust with rosuvastatin, so I would prefer continuing it. That.
With or without antiplatelet agent.
Antiplatelet agent, we have to use our clinical judgment. There is increased cardiovascular risk. Patients already having hypertension, hyperlipidemia. I would like to start antiplatelet in most patients with advanced diabetic kidney disease for sure.
With SGLT2 inhibitors being used now, so we are being able to continue the RAS inhibitors.
Correct.
So is there, despite all that, if the creatinine clearance drops to below 15 or 20, so SGLT2, I think we need to stop.
Correct.
So at that time, do we continue with the RAS?
Yes. So as per the data which I have presented today, RAS inhibitors needs to be continued. SGLT2 inhibitors are not harmful. Basically, they won't work when the EGFR is less than 15. They don't work only basically. So that's why SGLT2 inhibitors have to be discontinued. But whatever data is available till date, I think RAS inhibitors, they need to be continued. But we have to look at the serum potassium, as Sir has said just now.
So thanks a lot, sir. So now the delegates can move on for lunch. Thank you all.
Right.